Good morning, everybody. We welcome you all for this first session of the day, morning 8 to 10 poster session. We have a very eminent judge with us, Dr. Sylvia Rodrigues. She is the faculty of Terna Dental College, Mumbai. She has completed her BDS from D.Y. Patil Dental College, Pimpri, and her MDS from SDM Dental College, Dharwad. She has many publications, more than 40 publications to her credit. And the other judge for this evening, for this session is me. I'm an associate professor and a postgraduate guide from D.Y. Patil School of Dentistry, Navi Mumbai. I have many publications to my credit. So let us begin with this session today. And there are some rules for the participants. Please mute yourself and only unmute when you are presenting. You have to keep your video on when you are presenting the poster. Also, there will be 3 minutes that would be given to you. If you exceed the time, you will be interrupted and asked to stop because we are having time constraints. The judges will be given 2 minutes to ask the question answers. So we have to finish your poster in 5 minutes each. All the best to all the delegates. Let us begin with the first poster. Can we have the first presenter, please?
So a very good morning to everyone. I am Dr. Nidhi Saripalli and I will be presenting a review poster on concentrated growth factor, a marvel in periodontal regeneration. So as we all know, periodontal disease will eventually lead to the loss of tooth supporting structures, and the regeneration of these tissues is the ultimate goal of surgical periodontal therapy. Now, platelet concentrates, they have been used very frequently in recent times for periodontal regeneration, and they're of three types. Firstly, we have the platelet-rich plasma. Second is the platelet-rich fibrin, and third is the concentrated growth factor or CGF. So CGF is an advanced second-generation platelet concentrate, which is obtained by centrifugation of venous blood on a specialized machine called Silfradent. This was developed in Italy by Sacco in 2006. So CGF mainly differs from PRP and PRF mainly in its centrifugation speed. It has an alternating centrifugation speed. So it starts with a 30-second acceleration cycle followed by 2 minutes at 2700 RPM, 4 minutes at 2400 RPM, 4 minutes again at 2700 RPM, then 3 minutes at 3000 RPM, and ends with a 36-second deceleration cycle. So this basically leads to 4 phases. It forms 4 phases. First is the superior phase or the serum. Second, we have the interim phase or the fibrin buffy coat. Third is the liquid phase, which consists of all the growth factors. And fourth is the lower phase, which is made up of the red blood cells. Now coming to the functions of CGF. The functions of CGF are cell proliferation, matrix remodeling, angiogenesis, osteoblast proliferation and differentiation, and it also improves wound stability. The mechanism of action of CGF is that it acts by degranulation of the alpha granules of platelets, which results in the release of various growth factors such as platelet-derived growth factors, transforming growth factor beta 1 and beta 2, fibroblast growth factor, vascular endothelial growth factor, brain-derived growth factor, and insulin-like growth factor. Applications of CGF in periodontics is both for soft tissue as well as hard tissue regeneration. Procedures such as recession coverage. It helps in osseointegration, treatment of bone defects, ridge augmentation, as well as sinus grafting and socket preservation. Now, the advantages of CGF over PRP and PRF are that it has prolonged release of growth factors. It also has higher tensile strength, higher adhesive strength, and higher viscosity than PRP and PRF. Also, the difference in the centrifugation speed permits isolation of a larger and denser fibrin matrix, and it is also a low risk method. The main disadvantage of CGF is that it requires a specific centrifugation alternating speed, which can be achieved only on specialized machines and not on the regular centrifugation machines. And it also requires more research to be done so that it can be used more frequently in clinical practice. Thank you.
Okay, can you, Dr. Sylvia, you will ask the question?
Yeah, what is the exact advantage of CGF over PRF?
Ma'am, the main advantage of CGF is that it gives prolonged release of the growth factors. Like unlike PRF and PRP, CGF does not dissolve immediately after application. So the material it converts into a natural blood clot, which gives more prolonged release of growth factors at the site.
So can you compare the research by Joseph Shukron, who's given PRF, and Dongseok, who's given CGF, and tell me what exactly is the difference, and other than the machines, because Shukron promotes APRF machine and Dongseok works for sulfur-dentate lead. So that is why they are promoting and in their articles mentioning. But have you read both the articles in detail, and what exact difference personally have you found to promote CGF?
Ma'am, I am not aware of this.
Okay. Dr. Chanchal, you can go ahead with your question.
Okay. Nidhi, can you tell me, this is your review poster. Can you please let me know what kind of regeneration you get when you use any growth factor?
Ma'am, we get both soft tissue as well as hard tissue regeneration. So I have seen a lot of my seniors using PRF for endoperio lesions, furcation involvement defects. So.
Okay, thank you.
Thank you.
Can we have the next presenter, please?
Good morning, ma'am. Am I audible?
Yes, you are. Please start.
Yes, ma'am. A very good morning to all the respected panelists. My topic for poster presentation is soft tissue aesthetics around single implant restoration, a review. As we know, the goal of implant dentistry is to achieve aesthetic and functional harmony and integration of implant restoration with the surrounding hard and soft tissues, emulating the natural dentition. Proper representation of the critical and subcritical contour for a natural aspect of its peri-implant mucosa and the biomimesis with the adjacent teeth is a crucial aspect of the aesthetic area restoration. Various surgical techniques are available for soft tissue grafting and but the sculpting of the tissues using provisional restorations can achieve aesthetic contour. As we know, the main objective is to modify the peri-implant architecture while making the implant restoration biologically acceptable and also to allow the patient to maintain proper oral hygiene. In an immediate implant, we know that a critical contour has to be maintained on the palatal and interproximal aspect equal to the tooth, and on the facial aspect, it should be reduced by 0.5 to 1 millimeter, and the subcritical contour overall has to be maintained concave. Then, in delayed implant, we know that the critical contour, when the implant is at the ideal level, it should be maintained equal to the tooth. And if it is coronal to the ideal level, then it should be over-dimensioned in the apical and facial direction, and the subcritical contour should be concave. When the implant is apical to the ideal level, then it should be under-dimensioned in the apical and facial direction, and the subcritical contour must be maintained convex. By sculpting the critical and the subcritical contours, our main goal is to prevent any compression of hard and soft tissues and provide maintenance of the regeneration space. Understanding the concept of aesthetic biological zones is of utmost importance to facilitate a desirable aesthetic, biologically sound outcome for an implant restoration. Thank you.
Good morning, doctor. A good presentation.
Thank you, ma'am.
So, can you tell me about the interdental areas? I mean, can you throw some light about Dennis Gardner's article on interdental areas and how to achieve papillary?
Ma'am, there are various methods of like, ma'am, in the treatment of black triangle. Ma'am, that is why in especially in the anterior zones, the implants which are given are preferred to be given as immediate implants or early implants, and not delayed, because there is loss of soft and hard tissues. So when the early implants are given, there is reduced loss of soft tissues. So, ma'am, interdentally, ma'am, I don't know the technique, ma'am, but in the treatment of black triangles, it's given.
Yeah, I was not talking about the treatment. So this critical and subcritical contours was given by Huan Su in IJPRD only, I think some 20 years back.
Yes, ma'am.
In addition to that, when you design your provisionals, you also have to keep into account the contact points, or where you exactly give the contact points, so that you can contour the levels of interdental papilla as well. So that's what I wanted to know.
Sorry, ma'am, I'm not aware about.
No, that's okay. Dr. Chanchal, you can go ahead with your question.
Thank you, Sylvia. Mugdha, can you tell me what is the time duration that has to be taken into consideration when you come to this immediate implant and delayed implant restoration to have a proper emergence profile?
Ma'am, 4 to 5 weeks. Ma'am, in one article I had read 4 to 5 weeks, but I'm not very sure, ma'am.
Okay. Okay, thank you. Over to the next presenter, please.
Thank you, ma'am.
Yeah, good morning, ma'am. Am I audible?
Yes, Shivani, you are audible.
Yeah. Good morning, everyone. I'm Dr. Shivani presenting a poster today. The title of my poster is Mucormycosis and COVID-19 from a periodontist view. So coming to the introduction, mucormycosis is defined as an opportunistic angioinvasive necrotic fungal infection with a high morbidity and mortality rate. The causes of mucormycosis as listed are mainly a reduction in the CD4 plus T cells and the CD8 plus T cells, causing immune suppression. Other causes include trauma, poorly controlled diabetes, unnecessary use of corticosteroids, organ transplant, and prolonged stays in the ICUs. Next is the coronavirus disease, which, as we all know, is an infectious disease caused by SARS-CoV-2 virus. We all are well aware about its causes, and the main effect caused by COVID-19 infection is the immune suppression, and is hence directly related to the increased rise in mucormycosis cases. Now, the oral symptoms of mucormycosis is pain in the sinuses and teeth and the gingival tissue, multiple abscesses in the gingival tissue, palatal ulcers, loosening of teeth, periorbital swelling, etc. Now, we as periodontists use various diagnostic tools like non-contrast computerized tomography, CT, angiography, and MRI. So, coming to the review of literature, according to Brandau et al., oral manifestations of mucormycosis in COVID-19 patients are usually seen in palate and may include mucosal discoloration, swelling, and ulceration. Next, according to a report by McGill University in Montreal, Canada, there is a direct link between gums and with infection, inflammation, and even connected how oral hygiene can play a role in aggravating COVID-19 complications and even lead to death. Next, according to Dr. Mohinder Narula, taking care of oral hygiene can also safeguard from post-COVID-19 complications. Evidence suggests that in COVID-19, there is elevated levels of the virus in saliva and periodontitis linked to a higher risk of mortality. So researchers found that dental plaque buildups and periodontal inflammation increase the risk of SARS-CoV-2 virus affecting lungs and causing more serious infections. Now coming to the management, both medication and surgical management strategies are employed in such cases. Amphotericin B, oral posaconazole therapy on time, and ensuring that patient has a controlled blood glucose should be initiated, following which extensive surgical debridement should be used to remove the necrotic tissue. Now, next coming to the prevention, periodontists should ensure past medical history is taken prior to initiation of the treatment. Doctors should be advised to use steroids and antibiotics judiciously Periodontists should counsel patients regarding plaque control, proper oral hygiene instructions, and also inform about other comorbidities like diabetes, hypertension, heart diseases, etc. Last is the conclusion. We as periodontists specialize in the prevention, diagnosis, and treatment of gingiva, periodontium, and supporting alveolar bone. Oral mycosis is not a new fungal infection and has been diagnosed and responsibly treated by periodontists for a long time. So its successful treatment lies in early diagnosis, and we as periodontists can successfully eradicate the infection. Thank you.
Good morning. Are there any systemic morbidities or comorbidities that are present in the patient which make them more susceptible to mucormycosis?
Yes, ma'am. Actually, diabetes mellitus along with diabetic ketoacidosis, then organ transplant can cause
And
mucormycosis.
do you see this more in hospitalized patients?
Yes, ma'am.
So aren't these patients given steroids as a part of COVID treatment? And do you see the link between steroids and diabetes? If you can explain that and what happens systemically?
Ma'am, actually, corticosteroids will increase the blood glucose levels, as we can see that remdesivir along with other antifungal treatment therapies has caused increase in the blood glucose levels of the patient. So this can be a direct link between cause of increased mucormycosis cases.
Okay, good. Dr. Chanchal, you can go ahead with your question.
Thank you, Dr. Sylvia. Shivani, can you
Yes,
tell me
ma'am.
what is the prevalence of mucormycosis cases now, and what was the prevalence of mucormycosis cases a couple of months back?
Ma'am, actually, second wave has experienced a lot of increase in the mucormycosis cases. 74% recorded in Iran and 72 in Mexico, which and
No, I'm
India
talking
is
about here in India.
yes, ma'am. And India is the third leading country in increased mucormycosis cases
Okay,
since
so
last 2
I
years.
just wanted to ask you if you get a patient of mucormycosis which usually isn't suspected, so what is the take to do periodontal therapy in that patient? Should we do it or we have to wait, or what is the main protocol?
Ma'am, we as periodontists can get many referred cases from the dentist who do not understand gingival problems or periodontal related problems. And as we specialize in this, so I feel that we should go for the treatment. We should initially start with amphotericin B therapy or oral posaconazole.
Okay, thank you. Can we have the next presenter, please?
Good morning, everyone. Today I am here to present my topic, usefulness of CBCT in periodontology. CBCT is a technique which can provide us 3D images which are similar to CT images, but they give a relatively low radiation dose to patients and a high quality image of the heart tissue. CBCT provides rapid volumetric image acquisition taken at different points in time that are similar in geometry and contrast, making it possible to evaluate differences occurring in the fourth dimension. Now, where it is used, the indications of CBCT, it is used for evaluation of implant placement, endodontic evaluation, periodontal evaluation, then in bone resorption cases. Then it is also used for the study of airways, positioning of temporary anchoring devices, and also for the cephalometric analysis. The advantages, it has a rapid scan time. It gives complete 3D image to us. Its beam collimation enables the limitation of radiation to the area of contrast. Then there is reduced patient radiation. Multiplanar reformation is possible. Now, basically, we have to discuss about the periodontal applications for CBCT. It is used for periodontal ligament space assessment. Periodontal ligament space assessment is usually important so that we can diagnose occlusal trauma and effects of systemic diseases on the periodontium. Then it is also used for periodontal defect measurements. Bone defects are usually diagnosed with the help of CBCT, as it provides better diagnostic and quantitative information for the periodontal bone level. It is also used for measurement of periodontal bone levels, which is useful in implant placement. It provides a periodontist the relationship between gingival margin and facial bone crest, and also the relationship between gingival margin and CEJ. It is also used for the alveolar bone density measurement. In implant cases, we usually use CBCT as it provides us a accurate bone. It gives us an accurate bone level, so that the implant cases, so that we can place the implant correctly in our patients. And conclusion, intraoral and other extraoral radiographic techniques provides us a 2D image of 3D object. But the CBCT provides us a 3D image, which is said to be effective in providing essential information pertaining to the morphology of bone, available height, and width of alveolar bone at the implant site measurement. Thank you, ma'am.
Good morning.
Good morning, ma'am.
And do you know what is the FOV?
Ma'am, FOV?
Yeah, so when you prescribe a CBCT to a patient,
Yes,
depending on the applications, like if you want it for a sinus lift or a zygoma, you prescribe a different FOV. So do you know what is a FOV?
No, ma'am, I don't know about FOV.
It's field of view. So you have to prescribe it according to what implant procedure you are doing.
Okay.
Dr. Chanchal, you can go ahead with your question.
Can you please let me know the disadvantages of CBCT?
Yes, ma'am. The height. There are very less disadvantages. The high cost. The main is the high cost of CBCT. It is not economical for every patient to get a CBCT done, and it cannot offer a resolution with high contrast. Like, this is the disadvantage, which CT can provide, but CBCT cannot.
Okay, thank you. Can we have the next presenter, please?
Good morning, ma'am.
Good morning.
Ma'am, may I start?
Yes, please.
Good morning, judges and Manadal present here. The topic of my poster is effect of low-level laser on various cells in periodontal regeneration. Current use of laser in periodontics has gained a lot of importance in periodontal disease treatment, especially in relation to periodontal regenerative procedures. Various low-level laser therapies have been used and studied clinically as well as in laboratory with various specifications such as wavelength, power, energy, and time of application on periodontal cell, indicating its cellular function and proliferation with prime action seen at the nuclear, mitochondrial, and cell membrane levels. The objective of this poster was to give an insight into the use of this low-level laser in laboratory cell cultures, animal studies, and human studies related to the periodontal regenerative procedures with its specification and influence on each cell. Various articles were reviewed with a total of 57 articles collected in total. 8 articles were on animal studies, 13 on human studies, and 36 on cell culture studies. It was seen that gallium arsenide aluminum, light emitting diode, helium neon, NDYG, and diode lasers were used with maximum studies on cell cultures using diode lasers. Also, a total of 40 studies indicated the presence of osteoblast, 4 suggested the presence of cementoblast, and 13 suggested the presence of fibroblast in these periodontal regenerative procedures. So the results said that various wavelength of low-level laser therapy has strong proliferating effect on fibroblast, osteoblast, and cementoblast, fastening the healing effect on periodontal apparatus in these studies and surgical procedures. Also, this can be attributed to the stimulation of pluripotent cells, to differentiation of these pluripotent cells into osteoblasts, stimulating the alveolar bone, cementoblast, stimulating the cementum formation, and fibroblasts, stimulating gingival and periodontal ligament formation, hence contributing to the contributing to the periodontium as a whole. The tissue engineering concept provides the triad of signaling molecules, cells, and scaffolds. So the cells were highlighted through this study. Hence, concluding with this poster, the low-level laser has a good regenerative potential in periodontal surgeries with positive effects seen on fibroblasts, osteoblasts, and cementoblasts in total. Thank you.
Good morning.
Good morning, ma'am.
Where will you use low-level lasers in periodontal therapy? Like, what are the indications in periodontal therapy?
Ma'am, with each laser having specific specification to where to use, it has seen that when used at a low power, it can be used for procedures like gingivectomy, frenectomy, osseous recontouring, and like for soft tissue and hard tissue, ma'am. Like for this low-level laser are suggested for soft tissue procedures, ma'am.
Okay. Dr. Chanchal, you can go ahead with the question.
Yes, thank you, Dr. Sylvia. Diksha, can you please let me know which is the commercially available low-level laser you know of or you use in your department?
Ma'am, we have diode laser, ma'am.
So what is the frequency that you use?
Ma'am, we have
The low-level
810.
laser?
Yes, ma'am. Ma'am, diode laser, there are mainly three wavelengths, 810, 940, and 980. But we use 810 nanometer in our department, ma'am.
And what procedures you do with that?
Ma'am, we undergo phreniectomy. Ma'am, we excise mucosal with the procedure. Also, ma'am, like any excisional or removal procedures, ma'am, like scaling and root planning, we usually use ultrasonics only. But it has been advised to use in scaling also if necessary, but we also depigmentation procedures, ma'am.
Okay, okay. Thank you.
Thank you, ma'am.
Can we have the next presenter, please?
Good morning, ma'am. Am I audible, ma'am?
Yes, you're audible.
Good morning, everyone. Today I'm going to present poster on the topic curcumin, a game changer in periodontal therapy. As we all know, periodontal disease is one of the most common causes of the tooth loss among the adults. Research shows that inflammation is one of the most crucial component in initiation and the progression of the periodontitis. Initially, systemically delivered drugs were used in the treatment of periodontitis. It has some side effects. Later, it was replaced by local drug delivery. It was introduced by Dr. Max Goodson in the year 1979. It has some of the advantages such as drug limits at the target site and GCF concentration is higher, better patient complaints, the drug delivery is localized, and there is no systemic drug resistance. Some of the commercially available local drug delivery agents includes the tetracycline, minocycline, atridux, elizol, periochip. In the last few years, there are some of the natural compounds are used in the treatment of the periodontal therapy. One such natural compound is the curcumin. Curcumin is nothing but the turmeric. It belongs to the class curcuminoids, Flamlike Zingiberaceae. It is a natural compound which is in yellow color. It has two natural analogs, namely caffeic acid and ferulic acid. The properties of the curcumin include antimicrobial, antioxidant, and anti-inflammatory. It has also some of the additional benefits such as neuroprotective, anti-carcinogenic, and hepatoprotective. Coming to the mechanism of action, curcumin shows its anti-inflammatory effect by reducing the inflammatory response of a tumor necrosis factor alpha stimulated human endothelial cells by interfering the nuclear factor kappa beta. It inhibits the osteoclastic activity via suppressing the rankle-induced nuclear factor kappa beta activation. Curcumin prevents the nuclear factor kappa beta activation from entering the nucleus, thereby blocking the inflammation at an early stage. It suppresses the prostaglandin synthesis. Curcumin downregulates the activity of cyclooxygenase, lipoxygenase, and inducible nitrous oxide species. Coming to the advantages, though it is a natural compound and it is easily available, it may also be cost effective. Some of the applications include local drug delivery, topical application, photodynamic therapy. There are commercially available drugs for the topical applications such as Qnex gel and curcumin lozenges. But coming to local drug delivery, it is not commercially available. The main disadvantage is the bioavailability. It is a major challenge for preparing the curcumin gel as a local drug delivery. Though we are using some of the agents which enhance bioavailability, it includes pluronic F127, polysorbates, fenugreek, and gamgati solution. Finally, I conclude that curcumin gel can be considered as an adjunctive therapy to the scaling and root planning. Various studies show significant improvement in clinical and parameters. Since curcumin is natural and easily available, it can be a viable and a cost-effective option for a common man. Thank you.
Good morning.
Morning, ma'am.
Are there any other naturally occurring anti-inflammatory and antioxidant agents?
Ma'am, guava leaves.
Have you, are there any other anti-inflammatory and antioxidant naturally occurring agents? Do you know of any other agents that have similar properties?
Guava leaves, ma'am.
Anything else? Guava leaves you're talking about, okay? Anything else?
Yes, ma'am.
And if yes, then why did you choose only curcumin?
Ma'am, turmeric in this COVID situation, it is very.
Okay, one more question. How will you use curcumin in photodynamic therapy? I mean, you need a photosensitizer as a dye,
Yes,
and is curcumin that? I mean, how will you use it in photodynamic therapy?
ma'am, many articles shows that curcumin has the effect of photosensitizer, ma'am. It absorbs the light wavelength from
What kind
300
of
to
laser
500.
it absorbs light with what laser? What wavelength?
Ma'am, 300 to 500 nanometer, ma'am.
So what kind of laser will it be?
Ma'am, visible.
Okay, Dr. Chinchi, you can go ahead with your questions.
Okay, no questions. Thank you. Thank you.
Yes, ma'am. Thank you, ma'am. Thank you.
Can we have the next please?
Am I audible now?
Yes, you are.
Good morning, everyone. Today, I'm going to present about healing of the periodontal tissues following the phototherapy. Complete eradication of the bacteria is not achieved with the conventional mechanical therapy. Hence, agents such as antimicrobials and lasers are used. Lasers have various beneficial effects such as providing microbial inhibition, stimulation, biostimulation, and providing adequate hemostasis and decontamination. Basically, lasers are classified into two types. They are low-level surgical lasers and non-surgical lasers. Surgical lasers are again classified into hard tissue lasers such as LPM-YAG lasers and soft tissue lasers such as Nd:YAG, diode lasers, and CO2 lasers. And lasers that are included in the non-surgical therapy are low-level lasers. Depending on the depth of the penetration of the lasers, they are classified into two types. They are superficially penetrating lasers such as LPM-YAG lasers and CO2 lasers, and deeply penetrating lasers such as Nd:YAG lasers, CO2 lasers, diode lasers. And these deeply penetrating lasers produce thicker coagulum that interferes with the primary wound healing, but superficially penetrating lasers produce thin coagulum with minimal thermal side effects, leading to the efficient primary wound closure. Coming to the mechanism of the hard tissue ablation with the laser, hard tissue lasers such as LPM-YAG lasers produce are absorbed by the water molecules present on the hard tissues, leading to the micro explosions in the tissues. Thus, it contributes to the ablation of the tissues. Coming to the mechanism of the high-level laser therapy and low-level laser therapy, high-level laser therapy causes denaturation, decontamination, coagulation, vaporization, and carbonization with gradual increase in the temperature. And low-level laser therapy acts at a lower temperature, such as at 37 degrees centigrade, and it stimulates the surrounding tissues and the cells, leading to the increase in the fibroblast proliferation, and it also has anti-inflammatory effects. Coming to the effects of the laser on the soft tissue, both the deeply penetrating lasers such as Nd:YAG lasers and the diode lasers produce a greater moderate carbonization with thick coagulum, and superficially penetrating lasers such as LPM-YAG lasers produce a lesser carbonization and with thin coagulum, and CO2 lasers produce thicker carbonization with thin coagulum. Coming to the pocket therapy with the laser, firstly the root surface of the disease pocket is irradiated with the laser, and the epithelium and the connective tissue is removed, leading to the increase in the bleeding from the bone surfaces. Then low-level laser is applied for the stimulation of the surrounding cells and the tissues, and then the external epithelium and the connective tissue is removed, leading to the stabilization of the clot, thus improving the wound healing in the periodontal tissues. And the next picture is showing the bone surface treatment by BAR CO2 laser and LPM-YAG laser. BAR procedure produces a grooved surface on the bone, and CO2 laser produces greater carbonization on the bone surface, and LPM-YAG lasers also produces grooved surface but with finer edges and with minimal thermal side effects. Coming to the mechanism of low-level laser therapy, low-level laser therapy acts on the cytochrome oxidase of the mitochondria, leading to the increase in the ATP production and reactive oxygen species, and decrease in the PGE2 production and interleukin-1 beta, and it also leads to the increase in the vasodilatation. Deeply penetrating lasers such as Nd:YAG lasers and diode lasers produce thicker coagulant that interferes with the adherence of the incised surfaces. Thus, it interferes with the primary wound healing. To conclude, lasers.
Sorry to interrupt you, but your time is over. Dr. Sylvia, please, can we start with the questions?
Good morning. So you spoke so much about lasers and different types of lasers. So if you want to buy a laser for your practice, which one will you go for?
I'll adopt for FBM-MAC lasers, ma'am. These lasers have these lasers have minimal thermal side effects, and it also produces a thinner coagulum. Thus, it does not interfere with the primary insulin.
Okay, Dr. Senthil, go ahead.
What kind of healing after pocket elimination comes when you use laser?
Firstly, a clot is formed, ma'am. Then the epithelial surface will proliferate, leading to the primary wound closure, ma'am.
Okay. Thank you.
Thank you.
The next presenter, please. Please start.
Very good morning. Very good morning. Myself, Dr. Pratyan. My topic of presentation is periodontally assimilated osteogenic orthodontics. This procedure was first introduced by Dr. William Wilcon and Dr. Thomas Wilcon, both are known as Wilcon brothers, which is a combination of the selective decortication facilitative orthodontic technique with alveolar augmentation. The corticotomy is a procedure whereby only the cortical bone is cut, perforated, and mechanically altered using a controlled surgical manner, and the medullary bone is left over. The indication for this technique is in case of diastasis and penetration, and anterior open bite and deviated midlines, cross bites and arc length with discrepancies about 10 to 12 mm, and moderate to severe malocclusions. And contraindicated in patients with severe active periodontal diseases and endodontic problems, patients with medication like NSAIDs, bisphosphonates, and steroids which disturb bone remodeling. And the advantages of this technique include it decreases the treatment time, and it also has less likelihood to relapse, for as it decreases resistance to cortical bone, and it increases limits of tooth movement and decrease in need of extractions, alveolar restepping, increases patient profile and alveolar volume, and more structurally complete periodontia. The disadvantage of this technique is its extra surgical cost, and mildly invasive surgical procedure is also has chances of post-surgery complications like pain, swelling, and infections. And then the procedure includes the surgical technique, which includes the step one, which includes the basic flap design, which includes the combination of a full thickness mucoperiostral flap, which in the most coronal aspect, then the split thickness flap, which is preferred in the apical region. Then comes to the step two, is the decortification process, which acts on the basis of regional acceleratory phenomena, which is a vertical corticotomy incision is given, and then it is joined with the horizontal incisions. Then the step three include the particular grafting. The grafting material like autogenous bone graft, freeze-dried bone graft, and decalcified bone graft are being used. Then step four includes the closure of the technique, which the papilla followed by interproximal sutures are being given. Then comes I have included a modification technique which is given by Zindiama and GC et al., which introduce an improved surgical technique. In this, they raise the full thickness mucoperiostral flap, and then performing a circumferential corticotomy cuts and periosteal releasing incision, placing a grafting material, and they sutured the membrane together, and then a well-defined pouch is being created, which allows the tension-free closure of the periosteal flap. So this is my about the poster.
Good morning. Are you done with your presentation?
Yes, ma'am.
Okay, can you tell me other modifications of this?
Ma'am, the modification like piezo incision you can give in orthodontic modification. Then corticos incision when you can do also in this technique.
Okay, Dr. Chanchal, you can go ahead.
Can you tell me at what stage of ortho treatment does this is performed?
Ma'am, it is performed before the surgical corticotomy technique, 1 week before the surgery. Then after surgery, then after 2 weeks, we go for the osteotomy force application.
Okay, thank you. Can we have the next presenter, please? Next presenter, please.
Good morning, respected staff. Am I audible?
Yes, you are.
Okay, good morning, respected staff.
We can't see your video.
Now, ma'am.
No, your camera is off. Anyway, continue.
Okay. Myself, Roja Chimrala, pursuing my post-graduation from Megna Dental College, Nizamabad. Today, I'm going to speak about low-speed centrifugation concept as a new vista in regeneration. As we know that the original concept of PRF was to spin at high centrifugation speed in order to separate the layers, and as no anticoagulants were used in this concept, the resultant was in the form of a three-dimensional figurine scaffold. In original PRF matrix, we observe cells gathering at the bottom of the PRF matrix. And to avoid this, they suggested to reduce the relative centrifugation time as well as speed in order to increase the number of cells in the top layer. As centrifugation speed was reduced, we observed increase in cells and growth factors. When we use high centrifugation speed, we get a dense structure with less number of cells when compared to the matrix generated when we are using this medium centrifugation force. And this has led to the concept of low speed centrifugation concept, where by using the low centrifugation speed, we can get a more number of growth factors and inflammatory cells. And by using this low speed centrifugation concept, we can generate an advanced solid PRF matrix and a solid PRF matrix and injectable PRF matrix. And according to Choutron and his co-workers, advanced solid PRF is generated at 1300 RMP for 8 minutes in one cycle. In total span of this advanced PRF, more porous structure with large interfibrous space where cells are scattered all over the matrix can be seen. We observe more number of growth factors like transferrin growth factors, beta-1, platelet-derived growth factors, endothelial growth factors in this solid PRF, advanced solid PRF when compared to the original PRF. Different inflammatory cells were also observed in the middle and distal part of this advanced solid PRF plot. A newly trending IPRF is generated at 700 RMP for 3 minutes in one cycle. As we are using even low speed, we get more number of growth factors and inflammatory cells that fasten the wound healing in this injectable PRF. As the growth factors like platelet-derived growth factors and endothelial growth factors are present more in this injectable PRF when compared to the all other PRFs. So finally, this low speed centrifugation concept can be beneficial both clinically as well as in research purposes for both better understanding of cell-to-cell communication in wound healing process and the tissue regeneration. Thank you.
Hi, good morning. Can you tell me the indications of IPRF?
So this IPRF can be used as a plug during this extraction socket healing by mixing with the bone matrix, and we can use that in soft tissue root coverages and sole material in sinus elevation procedure and all.
Is IPRF mixed with something to form something?
Yes, ma'am.
What? That's what I'm asking.
So we can mix it with the bone material, bone grafts, and we can form a sticky bone.
Okay. Do you have any knowledge about the angle of the tube placed during centrifugation? There's this recent article by Richard Miron who says that the angle should be changed and what the centrifuges currently are available don't have an appropriate angle. So can you throw light on that?
I exactly don't have idea about that, ma'am, but I have read that angulation should be changed for the better generation of this PRF matrix.
Okay, Dr. Sensi, we can go ahead with your question.
Can you tell me what are the indications in periodontology of this IPRF?
So we can use in soft tissue root coverages, ma'am, by using this IPRF matrix.
Okay.
And even in extraction socket healing, we can use this IPRF matrix.
Okay, thank you. Can we have the next presenter, please?
Very good morning, ma'am. Am I audible?
Yes, good morning. You are audible. Please start.
Okay, ma'am. Okay. My topic is hyperhope, Liga plans in implant industry. Coming to the introduction, as we all know, the people has gained a popularity among replacing the lost missing teeth with their osseointegrated implants. A new technique has been introduced, which is a modern therapeutic tool, which is known as tissue engineered periodontal ligament cells, also known as Liga plans. It has a wide properties of evenly distributing the mass. It helps in the proprioception, it acts as a shock absorber, and so on. Coming to the difference between the osseointegrated and pedial integrated implants, formation of pedial happens around the titanium implants, which has been helps in the various way, which I've explained below. And coming to the tissue engineering, which helps in the formation of periodontal ligament cells, there are two types of techniques. One is ex vivo and in vivo. The three elements required for the formation of periodontal ligament cells is cells, scaffold, and signaling molecules. And coming to the preparation of ligament plants, the periodontal ligaments are the cell sources which have been extracted from the host autografted cells. After 14 days of extraction, which has been transferred into the Delbecos medium for the preparation of the periodontal ligament cell sheet, and further it has been transferred into the bioreactor for the formation of periodontal ligament around the dental implants. And coming to the interface of implant and periodontal ligament, a new cementum happens around the implants, orientation of fibers across the non-millisphere implant space, and bone formation and occurs around the ligaments. For the success of ligament plants, site-specific signaling molecules help in various ways, which is the mainly for the formation of bone. A gene called homogen MXX2 has been helpful. The inhibition of myelination of PL, aspirin, and SLP, small use in bridge protein protein helps in the way of inhibition of myelination. And coming to the advantages, alveolar and alveolar bone defects. It forms the firm integration without bone interlocking, and
Are you done with the poster, or you got disconnected, or he got disconnected?
No. Sorry, it's a network problem. Yes, coming to the disadvantages, it's a culture sensitivity, and it is expensive. Post acceptance is unpredictable, and the appearance of non-PDL results. So finally, coming to the precautions while preparing Liga plans, proper sterilization should be done, and proper culturing and cell growth is necessary. Micromechanical movements of the growth medium, and adequate duration of the surface treatment. So coming to the conclusion, Liga plans has decisive advantage compared to the osseointegrated implants due to their periodontal tissue regeneration and wide stability. Thank you.
Okay, so this is still in vitro research, or have they tried it in animal models?
Yeah, Lin et al. Back in 2011 tried the rat pedicle for the deletion of periodontal ligaments in titanium implants.
So what were the results of that study?
Sorry, ma'am?
What were the results of that study?
The study results says that he partially successful, but the recent studies have been saying that use of Liga plants around the in vivo studies of human trial have been failure.
Why do you think so? Because if you read the healing of osteotomy side, the first thing that comes in is osteoclasts. So, and inflammatory cells, and you put periodontal tissue there, you put periodontal ligament cells there. So how will the osteoclasts and inflammation affect it? I mean, you need to think about on those lines. Anyways, Dr. Chanchal, you can start your question.
No idea, ma'am.
Dr. Chanchal, you can go ahead with your.
Okay, Dr. Sylvia, thank you. No questions. We can go on with the next presenter.
Good morning, everyone. And my topic for poster presentation is peri-implantitis, how to prevent. As we all know, the dental implants are the current trending options in the dentistry. Although higher the success rate has been reported, there are certain situations where inflammation can be seen, and this condition is starts as a peri-implant mucositis, and which further, if it is left untreated, it leads to the peri-implantitis. There are certain factors we have to take into the consideration to prevent the peri-implantitis. Coming to the patient, disease control should be is the major factor. As periodontitis is the sixth most prevalent global disease, we have to eliminate this disease, and patients should perform good oral hygiene in order to have the good plaque control. And we have to advise the patient for smoking cessation, and the diabetic control should be at in a level. And coming to the implant design, 0.5 to 1 mm of smooth collar should be taken into the consideration to prevent the plaque retention. And moderately rough implant surface helps in osseointegration. Platform switch should be feasible. And non-metal implants like zirconium implants are to be taken into the consideration. Coming to the implant side, thick tissue phenotype and wide band of keratinosis because of greater than 2 mm helps in helps in decrease in the inflammation, and thereby causes the lower crustal bone loss. And in case of immediate implants, the periapical area should be free of infection. And also coming to the processes, when cement restorations are taken, there are chances of flow of excess cement, which leads to the secondary caries and secondary inflammation. Coming to the natural emergence profile, it is nothing but the contour. It should mimic with the adjacent tooth, and it should be less than 30 degrees in order to help in easy interdental cleansing. And coming to the light occlusal contacts, decrease in the occlusal overloading helps in causing the lowers the crustal bone loss. Coming to the clinician should be placing the implant in a proper implant 3-dimensional position and prosthetically driven implant position. And also we can take this help by giving the stunts in order to place the implant in a correct position. By considering all these factors, we can prevent the peri-implantitis. Thank you.
Good morning, doctor. Are you done with your presentation?
Yeah.
Okay. Did you attend Dr. Purnima Kumar's lecture yesterday?
No.
So what does she say about this?
No, ma'am, I was not I did not attend, ma'am.
So this was your topic. You should have attended
Yes.
that. Okay, tell me, what is retrograde peri-implantitis?
The infection will be spreading from the periapical area to the coronal areas.
Okay, Dr. Chanchal, you can go ahead with your question.
Can you please tell me what are the different grades or class of peri-implantitis you know of, or different types? And the management?
First, it will be starting as peri-implant mucositis. If it doesn't treat it, it will lead to progress to peri-implantitis.
Okay, thank you. Requesting all the participants to keep their video on and remove the mask while presenting. Next video, please.
Good morning, ma'am. Today I'm going to present my poster on microbial marks of health, gingivitis, and periodontitis. Coming to the health state, there is high tolerance for oxygenated environment like species like Rothia species and Corynebacterium species, which are aerobes. And also the streptococcus like Streptococcus actinomyces glamella, which are anaerobes. Of them, Rothia species are present in the early interaction, like in the early biofilms, and Corynebacterium species are also seen in early biofilm formation. So species are associated with the healthy, appear to be the species with demonstrated roles during the early biofilm colonization. So if there is a frequent removal of biofilm via oral hygiene measure, health state can be maintained. So these are the presentation where we can differentiate between the health, gingivitis, and periodontitis. And the dark color of the presentation in the health species are the species which are common between, which are exclusively for the health state. And in contrast, coming to the gingivitis, which is present in the green color. Coming to the gingivitis, these are enriched with a gram-negative anaerobic species, and there's a constant with the formation of new niche in the gingivitis, growth of oxygen-sensitive anaerobes, and almost all 11 species of Leptotrachea are appear to be enriched in gingivitis. And this shift in abundance of different species of Fusobacterium is also seen from the healthy states to the gingivitis. And in the gingivitis, mainly Fusobacterium nucleatum polymorphum has been found. Even this is also found in the periodontitis, but the state of this Fusobacterium nucleatum polymorphism is less when compared to the gingivitis, and also their abundance and specific virulent factors are more in gingivitis than compared to the periodontitis. And coming to the periodontitis, there are more gram-negative species present in this, and the virulence of this periodontitis is due to the because of the more specific virulence factors released by the bacteria. Even though the virulence factors which are released in the periodontitis compared to the gingivitis is in low abundance, their action is more like severe destruction can be seen because of the mainly the amount, the quality and the quantity, like they are the keystone species which are more responsible for the destruction. And also the species which are seen in the gray color are the core species, that these are the species which do not change in the quality or composition, whether they are shifting from healthy to gingivitis to periodontitis. So that means they are present in their level, but they do not change in the composition. So the destruction from the health to gingivitis to periodontitis mainly depends upon the abundance of the species. Even though they are present in the low quantities or the qualities, the virulence factors play a main role in them, and the emergence of periodontitis associated species with low abundance specific virulence factors dysregulate the host protective mechanism, which dysregulate the host protective mechanism and initiates that leads to the profound dysbiosis and leads to the destruction of the periodontitis, which leads to the periodontitis, mainly because of the keystone species which are present in that particular
Sorry
disease.
to interrupt you. You have exceeded your time limit. Dr. Sylvia, if you can start with the question.
Yeah, good morning. Can you throw some more light on polymicrobial synergy in dysbiosis?
Yes, ma'am. When we change from the health to gingivitis or gingivitis to periodontitis, it mainly depends upon the abundance of the species and the release of their specific virulence factors rather than that particular species.
Okay, can you tell me about co-aggregation bridges?
Yes, ma'am. Co-aggregation is like the aggregation of one species with the other species, that the primary colonizers, the secondary colonizers mainly depend upon the primary colonizers for their metabolism and the surveillance.
Okay, you can go ahead with your question.
Can you tell me what are gingipains?
Gingipains are released by the the other species of the performance gingivalis, ma'am. They are like of two types, gingivalis A and E.
Can you throw some light as to which organisms are responsible, or is it multi-factorial disease, periodontal health and periodontal disease both?
Yes, ma'am. Like mainly P. gingivalis plays a vital role in this, ma'am, which leads to more destruction of all the species, which is a keystone species.
Okay, thank you. Can we have the next presenter, please?
Thank you.
Am I audible? Hello?
Yes, Dr. Manisha, you are audible. Please continue.
Yes, ma'am. Yeah, I'll start. Good morning, respected jury and dear fellow participants. I'm Dr. Manisha here to present a review poster on the topic platelet concentrates in a revolution in dentistry. Platelet concentrates are a novel autologous material obtained by the process of centrifugation of peripheral blood used for tissue engineering and regeneration, and it is aimed at restoring the structure and the function of the altered oral tissues. The characteristic of platelet concentrates that enables its application in regenerative material is that it acts as a scaffold, serves as a growth factor, and also contains living cells. The platelet-rich plasma was the first generation of platelet concentrates introduced in the year 1954 by Kingsley by a two-step centrifugation process at 5,600 RPM, followed by 2,400 RPM with the addition of 2% calcium chloride as an anticoagulant, which produced a layer of buffy coat that contained platelets and leukocytes. In 2001, Chaukaran introduced the second generation of platelet concentrates called the platelet-rich fibrin, which contained no additives and higher concentration of immune cells, growth factors, and cytokines. The growth factors that were seen are platelet-derived growth factor, tissue growth factor beta, epidermal growth factor, insulin-derived growth factor, fibroblast growth factor, and vascular endothelial growth factor that stimulated the progenitor cells. The protocol for LPRF is that it is centrifuged at 2,800 RPM for 12 minutes. The third generation of platelet concentrates are the APRF, which was given by Chaukaran, prepared by the centrifugation at 1,500 RPM for 14 minutes, and A plus PRF at 1,300 RPM for 5 minutes. The IPRF was given by Monroe et al. By the centrifugation process at 700 RPM, and TPRF was given by Tonali et al. At 3,300 RPM for 2 to 3 minutes. The application of periodontics in periodontics is that for restoration of the defects of the bone, ridge augmentation, socket preservation, regeneration of intrabony defects, root coverage, increase in the thickness of the gingiva, and sinus lift procedures. Platelet concentrates are modified to enhance their reparative capacity by lyophilization and blending with biomaterials such as grafts or metal nanoparticles or stem cells, or in combination with some drugs. This led to the recent advancements like concentrated growth factors, which was given by Sacco et al. In 2006, and HPRF that was formed by horizontal centrifugation. To conclude, the role of platelets in wound healing and regeneration has led to the many advancements and applications in the periodontal regeneration and tissue engineering procedures. Thank you.
Hi, good morning. Can you tell me something about ALB or albumin PRF?
Albumin PRF, ma'am?
Or ALB, it's called ALB PRF, ALB PRF.
Ma'am, I have no idea about it.
Because that's the most recent thing. You should read about it. Dr. Chanchal, you can go ahead with your question.
Thank you, Dr. Sylvia. Dr. Manisha, can you tell me, with so many platelet concentrates coming, which is the most effective one and which is the most widely used one in these times?
Ma'am, currently the most widely used one is the APRF because of the amount of growth factors and the duration of the release of the growth factors that is present. APRFs is the most effective, but application of other PRFs like IPRFs is also increased because it can be used along with to increase the gingival thickness. The gingival biotype can be increased with injecting IPRF.
Okay. Thank you so much. Can we have the next presenter, please?
Am I audible?
Yes, you are. Please start.
Good morning, judges. Myself, Dr. Kavinder Kaur. I'm going to present a poster on the topic, how about shield the surgical field. One of the major goals of prosthetic rehabilitation is to maintain and achieve the harmony between the white and pink zone in the aesthetic areas. Tooth loss has always been a challenge in the dentistry because of physiological alteration that occur after extraction. Atraumatic extraction with immediate implant placement leads to loss of buccal bone both horizontally and vertically, resulting in complicated rehabilitation. So to overcome this, Hosler et al. Introduced socket shield technique, and the principle is to prepare the root of a tooth which is indicated for extraction in such a manner that buccal section remains in place. This technique is also known as partial extraction therapy. So the procedure is like, first, anesthetize the area, then cut the crown horizontally at gingival level, bisect the root, and the palatal half of the root is removed with its apex. Length of the shield should be 2/3 of the root length, and then the buccal part is reshaped with a width of around 1.5 to 2 mm. Then there will be a placement of implant. Optimum space between the implant and the shield is 1.5 mm to 2 mm, and if it 1.5 mm or more, and if it is more than 3 mm, then a graft should be placed. After that, a provisional crown is placed to maintain a soft tissue contour. Its types are buccal shield, full C buccal shield, half C buccal shield, interproximal shield, lingual palatal shield, and multiple buccal shield. The advantages of this technique is it helps in maintaining a part of the root to preserve hard and soft tissue contour. It minimizes the need of grafting procedure and thereby shortens treatment duration. It also helps in maintaining the pink and white aesthetics, and the interdental papilla can also be preserved by giving the interproximal shield. The limitation of this technique is it is highly technique sensitive. If the shield becomes mobile during surgery, it is removed and the conventional immediate implant placement is preferred. The case selection is also very important, and it is not recommended in the teeth that are mobile, out of arch, and with large periapical lesion. So partial extraction therapy open new prospects of treatment option in this era of high aesthetic demands and the ever-growing field of implantology. The data available on this technique is very limited and require more histological studies and the long-term clinical follow-up of cases treated using this method. With this, I conclude my presentation. Thank you.
Good morning.
Morning, ma'am.
Can you tell me what is root membrane treatment?
Root ma'am, in this we used to preserve the whole alveolar bone beneath the complete denture.
No, I'm asking about root membrane technique.
No idea, ma'am. Sorry.
Can you tell me what's Pontic shield?
Yes, ma'am. It is same as that of the socket shield technique. On Pontic shield, we use a graft with the shield to maintain the alveolar ridge and buccal plate.
Okay, Dr. Chanchal, you can go ahead with your questions.
Thank you, Dr. Sylvia. Can you tell me what is the longest follow-up in your this socket shield technique that you have come across? The longest follow-up with the use of socket shield?
Ma'am, 6 months.
6 months. So 6 months is enough to conclude that this socket shield technique.
Actually, ma'am, according to a review article, it's written as 3 months and 6 months post-operatively. Radiographic and clinical evaluation.
Okay. Thank you. Can we have the next presenter, please?
Hello. Good morning, ma'am. Am I audible?
Yes, you are audible. Please start.
Hello.
You are audible.
Okay.
Please start.
Good morning. Okay, ma'am. Good morning, judges. Respected my colleagues and respected judges. Today, I'm going to present my poster on bone anabolic drug. a prospective future in periodontal regeneration. Periodontitis, as we all know, is an inflammatory disease of the supporting tissues of the teeth, resulting in progressive attachment loss and bone loss. Periodontal regeneration involves the healing after periodontal surgery that results in the restoration of attachment apparatus, namely cementum, alveolar bone, and periodontal ligament. Bone anabolic agents are the medications that promote new bone formation by activating osteoblasts and are used to reduce the risk of osteoporosis-related fractures. Its mechanism of action. There are many anabolic drugs currently used, namely teriparatide, albenoperatide, strontium renylate, and romosozumab. These albenoperatide and romosozumab mainly act on the sclerotonin, which is a glycoprotein which is present in the osteocyte, thereby inhibiting the one beta-cat pathway, which is responsible for the bone formation, thereby reducing the bone formation. These drugs will act on this sclerotonin, thereby upregulating or enhancing the bone formation and reducing the bone resorption. And also, teriparatide, along with this action, it also directly acts on the osteoprogenitor cell, thereby there will be conversion of pre-osteoblast cells to the osteoblast, thereby increasing the bone formation. Also, denosozumab, they will inhibit the Rankel system, that is, they are which are responsible for bone resorption and thereby upregulating the bone formation. Some of the anabolic drugs include teriparatide, which is a synthetic analog of recombinant analog of parathyroid hormone. It is consisting of N-terminal 32 amino acids, which is similar to a portion of parathyroid hormone. Hence, it is also known as human parathyroid hormone agent. Albenoperatide is also a synthetic analog of parathyroid hormone. Strontium renylate, they directly act on the calcium sensing receptors, thereby upregulating the bone formation and downregulating the bone resorption. Romosozumab is a humanized monoclonal sclerotonin antibody, which is categorized under a new category of drug. The effect of these drugs on periodontal tissues includes increased bone mineral density, it increases the height of alveolar bone, increases the bone formation and periodontal healing, and it also helps in the periodontal ligament cell proliferation. I hereby conclude that, considering the pathophysiological mechanism of periodontal diseases, there is a strong rationale for using osteoanabolic agents as potential adjuvant treatment, which enhances bone remodeling, particularly bone formation, resulting in bone accrotal. Thank you.
Good morning.
Yeah, good morning, ma'am.
These drugs are to be used in severe cases of osteoporosis. So how will you defend its use for periodontitis, and what are the potential side effects of these drugs?
Ma'am, these drugs only having some clinic is undergoing some animal studies. Only teriparatide drug has undergone one clinical studies. In this study, they have stated that these drugs can be used as an adjuvant to scaling and root planning therapies. And the side effects includes long-term use of teriparatide will cause osteosarcoma. Then mild side effects includes dizziness, vomiting, etc. And strontium renylate and romosozumab, they also have a history of cardiac problems, higher incidence of myocardial infarctions on long-term uses.
Okay, thank you, Dr. Chanchal. You can go ahead with your questions.
No questions. We can go on with the next presenter, please.
Thank you, ma'am.
Thank you.
Ma'am, am I audible?
Yes, you are. Please go ahead.
Good morning, everyone. My presentation is on evolution of platelet concentrates. Now, we know that the fundamental goal of periodontal therapy is to restore the host tissue to their original design and function through regeneration. Platelet concentrates are products that result from centrifugation of a blood sample, and the platelet-rich plasma thus obtained are used in various ways to enhance the periodontal regeneration. Historically, the primary use of platelet concentrates were in oral and maxillofacial surgery, and is dated back to 1954 when Kingsley and Matras used the material as fibrin glue to seal wounded tissues. It was only after a decade that Knighton demonstrated the regenerative potential of platelets. The first generation platelet concentrates were introduced, that is a platelet-rich plasma. But it needs an anticoagulant which has shown to interfere with the angiogenic potential of the platelets. Now, this led to the development of the second generation platelet concentrates by Chokron, which are known as the platelet-rich fibrin. In this generation, the lower centrifugation rate leads to a well-organized fibrin matrix that favor the slow and gradual release of growth factors and has better efficiency in stem cell migration and wound healing. The different preparations of PRF which have evolved over time are APRF, described by Ganati, which utilizes a decreased RPM and increased time, which results in PRF matrix with more concentrated cells, enhancing tissue regeneration through the presence of macrophages. Now, TPRF is another advancement where they use titanium prepared PRF, which uses titanium tubes for blood collection, unlike the glass tubes. Tonali compared LPRF with TPRF and found that the latter has superior qualities in a way that the fibrin matrix so formed is much more polymerized, and hence it may last longer in the tissues. Then we have the injectable PRF, and it has been pursued with the aim of delivering to clinicians an easy to use liquid formulation, which can be utilized alone or in combination with other biomaterials. Now, all these above mentioned protocols uses a fixed angle centrifugation. Very recently, Myron et al. Used a horizontal centrifugation protocol and observed two very interesting phenomena. That is, first, the platelets and leukocytes concentration increased by 25 to 50% when compared to fixed angle centrifugation, and that the cells are evenly distributed in the fibrin matrix, making it much more useful as a graft. Now, since the discovery of beneficial properties of this biomaterial nearly 3 decades ago, the question remains, why is it still that the platelet concentrates are still not very popular as a graft material? It is because it has certain disadvantages, like a very short-lived lifespan, as it gets dissolved in the tissues in nearly 2 to 3 weeks. And also, to actually see how much of a true regeneration it is capable of, we need more animal and human histological evidence to substantiate it. Nevertheless, they are easily acceptable to patients because of its low cost, low morbidity, low post-operative complications, and easy manipulation as it is obtained from the patient itself. So for these reasons, platelet concentrates are definitely here to stay, and if researched upon further, they definitely have the potential to redefine surgical periodontics in near future. And as the saying goes, nothing is really old and outdated. One needs to just innovate or renovate to keep things alive. Thank you.
Hi, can you throw some light on CGF and autologous fibrin glue?
Ma'am, autologous fibrin glue was the first, the use of platelet was first used as a fibrin glue only, where it was used to seal the wounded tissue. Recently only, ma'am, the concentrated growth factor concept has come, where they lower the RPM, and they see that the lesser is the RPM or the centrifugation speed, the liquid which is formed, it has much more concentrated growth factors. It is a liquid formulation. So, and then recently we have the albumin CGF also, which they have seen that it has extended release in the tissues. Like the normal PRF, it has time of 2 weeks, and after that it gets dissolved. But the recent one, which is the albumin CGF, it has an extended release up to 4 months.
So why does PRF or albumin PRF have extended release? Like, what do they do?
Ma'am, I briefly read about it, ma'am. I think they denature the plasma which is there. They denature the protein. So I think that is the concept behind it being more present in the tissues for a long time.
Yes, Dr. Chandra, you can go ahead with your questions.
Can you tell me the difference between PRF and PRP?
Ma'am, PRP is platelet-rich plasma. The difference mainly lies in the centrifugation process. In PRP, what they did is they had to, after centrifugation, they had to put an anticoagulant to activate the coagulation cascade, after which the growth factors had released. But in PRF, they changed the centrifugation time in such a way that the gel which is the matrix which is formed is already coagulated, and the growth factors are much more present in PRF, and also there is less time in PRF. There's just only one centrifugation cycle, so it's easy to use, ma'am.
Okay, thank you. Can we have the next presenter, please?
Ma'am, am I audible, ma'am?
Yes, you are. Please go ahead.
Good morning, everyone. Today's my poster presentation is on the topic microRNA's role in periodontics. Coming to the introduction, periodontal disease is caused by host immune and inflammatory response to the bacterial infection of the teeth. The periodontal disease, when untreated, it progresses from mild to severe tissue destruction, and the common inflammatory alveolar bone defects are the periodontitis and the periimplantitis. The host response to the bacteria, it consists of the two different immune systems, that is the innate and the adaptive immunity. And the microRNAs are the single-stranded non-coding RNAs with an average length of 22 nucleotides. They regulate the gene expression post-transcriptionally by binding to the complementary sequences in third untranslated region of the target RNAs, resulting in either blocking the translation or the degrading of the mRNAs. During the immune and the inflammatory responses, the microRNAs target the inflammatory regulators and affect the magnitude of the inflammatory response. The dysregulation of the microRNAs expression in the tissues is reflected in the body fluids, so they can be used as a specific and the sensitive biomarkers. The expression of these microRNAs, that is 146 family and the LET7 family, and also the microRNA 144-5T, are upregulated in periodontal lesions, leading to the worsening of the tissue destruction, and which is through the toll-like receptors, nuclear factor kappa B, and other pathways also. And the overexpression of the microRNA 21, microRNA 155 induces the release of pro-inflammatory cytokines, and the microRNA 21 deficiency leads to severe periodontal bone loss, while the knockdown and the reduction of microRNA 155 increases the tumor necrosis factor alpha induced inhibition of the osteogenesis. The microRNA 223, 27A, and 128 are strongly linked with the bone remodeling, and the microRNA 27A, 128 are downregulated in periimplantitis, which is also closely associated with the alveolar bone dysfunction. So the manipulation of the microRNA's function to modulate the exuberant inflammation associated with the tissue destruction may have therapeutic potential for the treatment of periodontal diseases. And the microRNAs levels may be enhanced or limited by the microRNA mimics, which are chemically synthesized short-stranded oligonucleotides that mimic the pre-microRNA complex. And the other is the microRNA antagonists, which are single-stranded oligonucleotides that complement the microRNA sequences designed to reduce the microRNA activity. So, therefore, to conclude, the microRNA therapeutics hold a great promise for the future of periodontal therapy because they have the ability to modulate the immune response to the infection when applied in conjugation with the conventional periodontal therapy. Thank you.
So, have there been any research on animal models or human models?
Yes, ma'am. According to Wu et al. In 2003, ma'am, we have used the microRNA 27A and they have delivered it in the canine implant model, ma'am. And this have achieved the gain in the attachment levels and also the increased alveolar bone levels. This is conducted in 2003, which is in vivo study. And there have also been studies in the animal models, ma'am. And one of the study is by Yan et al., where they have delivered this oligonucleotides for the treatment of model periodontitis in that models, and there has been a decreased immune and inflammatory response, which is observed in this model.
Okay, Dr. Sanchil, you can go ahead with your questions.
Thank you. Can you tell me any form of periodontitis which has a linkage to the genetic relation?
Aggressive periodontitis can be seen hereditarily.
So what is that gene that gets into the linkage where the genetic involvement is usually seen? Okay, no. Thank you. Can we have the next presenter, please?
Ma'am, am I audible?
Yes, you are. Please start.
Good morning, all. My poster presentation topic is the microbial profile of periimplantitis. Dental implants as a procedure to replace natural teeth lost due to dental caries, trauma, and periodontal disease has been a major advance in the management of edentulous and partially edentulous individuals. Dental implants have shown highest survival rates up to 99% over 10 years. But the most common reason for biological failure of implant is periimplantitis. So periimplantitis is a plaque-associated pathological condition occurring in the tissue around dental implants, characterized by inflammation in the periimplant mucosa and subsequent progressive loss of supporting bone. When an implant is inserted into the oral cavity, it provides a new and physically different surface for the colonization of microorganisms that might be residing in that area already or enter the oral cavity during biofilm development. One may distinguish a collective consent that suggests the periimplant and the periodontal sites to behave as a distinct ecosystems that differently shape the quantitative and the qualitative composition of the residing microbiota with limited influences from nearby niche. So there are differences in the ecosystems lie in that the implant enveloping bone has a sparse blood circulation and is lacking proper innervation in a clear contrast to the natural teeth, which have bone support and they are held tightly with the periodontal, rich in periodontal ligament, which is rich in blood vasculature and nerve supply. There are some systematic reviews, for example, Loffrey et al. And Sherman et al. According to them, the periimplant sites harbored a less diverse microbiota than periodontal sites in both health and disease. There are few bacterial taxa, such as staphylococci, frequently appear to be distinctive of periimplant niche. The conclusion is periimplantitis represents a heterogeneous mixed infection that includes periodontopathic microorganisms, uncultivable asaccharolytic, anaerobic gram-positive rods, and other uncultivable gram-negative rods, and rarely opportunistic microorganisms such as enteric rods and S. aureus. Thank you, ma'am.
Good morning. Do you know the role of titanium oxide that's played in the pathophysiology of periimplantitis?
Ma'am, actually, these are the modifiers which are used, which actually, there is a roughness in the periimplant, in the area. So they actually help to decrease that thing and further decrease in the accumulation of plaque.
Okay, tell me different surface decontamination agents that you can use for the treatment of periimplantitis. Implant surface decontamination methods for the treatment of periimplantitis.
Ma'am, one is scaling and root planing.
You will scale the implant, scaling and root planing. I mean, I'm talking about periimplantitis here.
Sorry, ma'am. Sorry, ma'am. I don't know.
Okay, Dr. Chanchal, you can go ahead with your questions.
Okay. Thank you. Hello? Can you hear me, Dr. Manisha?
Yes, ma'am.
Can you please tell me the difference in the microbiological aspects or microbiota when it comes to periimplantitis and periodontitis?
Yes, ma'am. It is the periodontitis. There is a diversity which has more of anaerobic gram-negative rods, and in the periimplantitis there is more of asaccharolytic, uncultivable gram-negative rods, and mainly they have less of Probotella intermedia. They have seen less of that and more of actinomycosis species.
Okay, thank you. Okay, can we have the next presenter, please?
Good morning, ma'am.
Yes, please start.
Today my topic is time-in-basic periodontal therapy, which is given by William Hoisington in the year 2005, which is a non-invasive microscopic periodontal therapy focusing on manipulating risk factors released from the immune system. This includes various steps, and the first step is the DNA testing, which is used to identify the bacteria and to ultimately choose the antibiotic of choice. The second step is the bone one-session treatment, which is an aerobic procedure that prevents the periodontal disease in deepest pockets and supporting alveolar bone. This bone one-session treatment uses a stretch flap technique, which is done in 3 steps. In the first step, the culate is inserted inside the sulcus, and the stretching is given by applying mild pressure to the tissue and simultaneously removing the plaque and calculus. And in the second step, the trajectory is changed to a circumferential motion to create an incisional flap. In the third, that is the final step, culates are inserted to allow the rounded tip to remove the granulation tissue and tassy the bone surface. The goal of this entire therapy is to create a smooth, regular bone surface and fresh bleeding to flush out the toxins from the porosities. The healing happens with the help of the stem cells from the periodontal ligament. A clot attached to the clean bone surface acts as the scaffold, and the stem cells move along the scaffold and up the root surface at the rate of 0.05 mm per day within 8 days, and it thickens the layer of the clot. To permit this, it is important to keep the epithelial attachment away from the roots by proper oral hygiene techniques, which include daily brushing, flossing, and usage of aerobic oral hygiene kits such as Perio 8, which are specifically designed to clean the gingival region and to remove the disease-causing anaerobic bacteria. And controlling occlusal forces is also an important step. That is, the weakened periodontium cannot take even the normal occlusal pressure. It becomes traumatic. So to modify them, coronoplasty, enamelloplasty, or occlusal splints can be given. And the further steps include the lifestyle modification, nutrition, and exercise, which also contribute to the periodontal regeneration. And the healing process occurs by the formation of mineralized acellular connective tissue, attachment, and eventually the formation of bone within 9 months. On the day 1, the bone one session treatment is done, and on the day 2, oral hygiene regimen is begun. And day 3, clot is stabilized, and on day 4, pocket starts to fill in. On the day 5, there will be reduction of inflammation, and day 8, there will be sealing up of the pocket. On the day 14, the normal chewing regimen can begin, and on day 30, the complete pocket fill up occurs, and on the day 45, the bone begins to heal. On the day 90, bone completely fills in. So to conclude, the primary periodontal therapy can alter the pathogenesis by removing the etiological factors as well as guide the tissue for regeneration and new attachment. Thank you.
Hi, good morning. Why do you do DNA testing in the beginning? Because whatever microbes come in the test, the remaining treatment remains the same, right? So what can you highlight the role of that DNA testing in the beginning?
In order to properly prescribe the antibiotic of choice, DNA testing is done, ma'am. Like according to the microorganism, the antibiotic can be prescribed.
Can you give example of what microbe you will find and what antimicrobial you will prescribe accordingly?
For aggregative bacter, we can give tetracyclines, ma'am.
And if you find some other group?
Amoxicillin.
Amoxicillin.
No, ma'am. Augmentin. That's amoxicillin, clavulanic acid.
That's only augmentin. You directly prescribe augmentin for periodontal therapy?
No.
It's okay. Dr. Chinchal, you can go ahead with your questions.
Can you tell me that what is the advantage of using this, and can this be used in, what are the indications rather when can you use this triaminophasic periodontal therapy?
This is a non-invasive therapy, ma'am, and it provides a faster healing, and it is also more comfortable to the patient, and it's typically more
indications, not the advantages.
Indications.
Where do you use
this? Can be indicated in teeth which otherwise are extracted, ma'am. Like
sorry,
for periodontal region. If the teeth, if otherwise are intended to extract, in those cases, this therapy can be done, ma'am.
So you mean to say the prognosis of the tooth is hopeless is when we can use this technique?
Yes.
But why do we want to save the hopeless tooth?
Like periodontal regeneration is done in this procedure, ma'am. So.
Okay. Okay. Thank you. Thank you. Can we have the next presenter, please?
Good morning, everyone. Am I audible, ma'am?
Yes, you are audible, doctor. Please continue.
Good morning, ma'am. My topic is role of magnification in periodontology. Periodontal health has been a major concern among the adult population worldwide, with the destructing periodontal tissue exerting a negative impact on the normal mastication, speech, and aesthetics. Modern day patient envisions and expects treatment delivered to them in the most painless and minimally invasive manner. A therapeutic revolution using magnification and microsurgery in periodontal therapy has changed the clinical outcome of both surgical and non-surgical success in the practice. The types of magnification systems used are simple loupes, compound loupes made of Galilean lenses, complex loupes made of prismatic lenses, surgical operating microscope, periondoscope, and varioscope. The principles of microsurgery are improvement of motor skills, thereby enhancing surgical ability, emphasis of passive wound closure with the primary apposition of the wound edges, application of microsurgical instruments and suturing to reduce tissue trauma. The various indications of the magnification in periodontology are diagnostic procedures. Mamunjeas explained the use of magnification in diagnostic as well as non-surgical periodontal therapy. Dr. Rashmi Hegde et al. Gave the use of magnification in mucogingival surgeries, reported that the magnified view enhances the visual associativity and superior approximation of wounds, rapid wound healing, decrease postoperative morbidity, and increase acceptance by the patients. The regenerative procedures and the implant therapy. Advantages of this magnifications are improve quality in the patient care, higher magnification and brilliant illumination makes it easier, increases precision, improved ergonomic benefit, improving oral dental care, provides an open field for the surgery so that the microsurgical instrumentation is possible. The drawbacks is the cost is high, restricted area of vision, loss of depth of field as magnification increases, loss of visual reference point. Conclusion: the new area of using surgical microscope in all the procedures in dentistry and in periodontics especially is gaining popularity. The main reason is that the magnification helps in the better diagnostic ability, enhances the treatment quality, thus resulting in the enhanced patient care, ergonomic benefits to the operator, which are the prime factor for the treatment success. Thank you, ma'am.
Hi, good morning. Can you name some minimally invasive techniques for periodontal flap using surgical instruments?
Ma'am, Miss, no, ma'am.
Okay, Dr. Chanchal, you can go ahead with your questions. Dr. Chanchal, you can go ahead with your question.
Okay, yeah. You attended the pre-conference on this role of magnification by Dr. Hegde sir on the first day?
A bit, ma'am.
Sorry?
A big part of that, ma'am.
Okay, so what loupes do you prefer and suggest? Either loupes or microscopes? What is your take on that?
Ma'am, initially it should be loupes, ma'am, so as to get adapted. Initially, when we are going into magnification, one should start with the loupes and later upgrade to the microscope. And in the loupes, ma'am, there are TTL loupes and there are this flip up loupes, ma'am. You can use this. I'd suggest for the flip up loupes, as they have better declination angle, which can help to get a better ergonomic operator position, ma'am.
Okay. Thank you. Yeah.
And the recently by Nobel Biocare or optics, ma'am, there is zoom in and zoom out loop has been introduced by them, ma'am. Thank you, ma'am.
Okay, thank you. Can we have the next presenter?
Hello. Good morning, ma'am. Am I audible?
Yes, please start.
Good morning, everyone. So I shall be presenting a poster on orthogonal dental block, a novel approach of the periodontal regeneration. So a tooth is the simplest thing one could think of to be used as a bone substitute material, and the easy availability makes the job even easier. Now, according to Yoshida et al., there are many similarities between teeth and bone. First, they share the same origin, that is the neural crest. And second, the chemical composition of bone is very similar to that of teeth, especially dentine. Now, dentine and alveolar bone, they make up around 65% of the inorganic substance and 35% of the organic substances. It also contains some growth factor, which is, dentine also contains some growth factor, which is common to bone, like insulin growth factor, transforming growth factor beta, and bone morphogenic protein. Now, dentine also contains various proteins like osteopontin bone sialoprotein, dentine sialoprotein, osteocalcin, due to which it was considered as an effective alternative bone grafting material. Now, there are no reports of allergies or inflammation till date, and only shortcoming is the sacrifice of a healthy tooth to obtain the tooth bone graft. However, this problem is solved by using a third molar, which are indicated for extraction in most of the cases. Now, the dentinal matrix obtained from a tooth has to be demineralized before using as a graft, bone graft material. And the demineralized dentinal matrix is highly biocompatible and can support the cell growth and proliferation. It is osteoconductive with the host cells and has a long shelf life. Now, there are two types of demineralized dentin matrix that we have. We have autogenous and allogenous. Now, for preparing the dentin third molar were obtained and they were then crushed in the liquid nitrogen, washed in the sodium chloride, 1 molar sodium chloride, and demineralized in an acidic medium like acetic acid or hydrochloric acid, which has a pH of approximately 2. Then it is rinsed in cold distilled water, and finally it can be used as a graft material. Now we have a smart dentin grinder that is designed to crush and sort the extracted teeth into tooth particles of specific sizes. Now, Kim et al. Have conducted a large number of studies and was successful in finding out that the autogenous demineralized dentin matrix can be used for alveolar ridge augmentation, tooth socket preservation, and for sinus lift. Now, there is a technique which is called as the tooth shell technique. A proof of concept with the use of autogenous dentin block graft by M. Posh, and this was the article was published in the Australian Dental Journal in the year 2021. Now, in this tooth shell technique, a technique consisting of fixing a thin tooth shell to the bony defect. Now, the hollow space which is created is filled with the particular dentin of the remaining tooth. Now, tooth shell technique showed promising results for the reconstruction of the lateral alveolar crest defect, and it may be considered to serve as an alternative material to avoid bone harvesting procedure. In a study by Catherine et al., the dentinal graft was used in combination with LPRF and liquid fibrinogen. So LPRF is the second generation of platelet concentrate obtained by a single centrifugation without additives. This but an inexpensive technology has shown to be able to enhance the healing process and to promote the tissue regeneration due to the presence of platelet and leukocytes, which release growth factors and cytokines which are involved in healing process. Pioneer studies performed by Yeoman and Juris that prove that autogenous demineralized.
Sorry to interrupt you, Harshita. Dr. Harshita, you have exceeded your time and we can't see your video. Okay. Your video is off.
My video is on. Actually, I'm at the airport, so there might be some internet problem. I'm so sorry.
It's a poster. You should have been logging in by. Anyway, Dr. Sylvia, please.
Yeah, you have shown the Cometa Bio grinder here. Do you know any other commercial grinders available for using dentin grafts?
Sorry, no?
What you have shown in your poster is a Cometa Bio dentin grinder. Do you know other commercially available dentin grinders?
Ma'am, we have. I don't know, ma'am. I don't know.
Okay, another question is why do you need to use a commercially available dentin grinder? Why can't you just use a normal coffee grinder?
Ma'am, because of the particle size that we need, specific, like we have one dentin grinder, the smart dentin grinder, that is basically designed to crush and sort the extracted teeth into the tooth particles of the specific sizes.
Something called as pulverization. It pulverizes the dentin. Anyways,
okay,
Dr. Chanchal, you can go ahead with your questions.
Thank you, Dr. Sylvia. Can you tell me what is the advantages of this autogenous dentin block over the autogenous bone graft?
Yes, ma'am. So being autogenous, it leads to the absence of antigenicity. So secondly, it is very safe and effective bone graft material. Autogenous demineralized dentine is an ideal scaffold for stem cell and bone growth factors. And compared to autogenous bone, the use of autogenous dentine offers the advantage of avoiding the harvesting procedure and the possible resulting donor site morbidity. So, and also it shows significantly less absorption because it is denser and has neither old vascular channels nor marrow spaces, unlike bone. So for this reason, we also do decalcification of this teeth before it is used.
Thank you, Dr. Harshita. Can we have the next presenter, please?
Good morning, ma'am. Am I audible?
Yes, please go ahead.
Yeah, okay. Infection control plays a critical role in preventing the spread of disease in healthcare settings. COVID-19 is an infectious disease which is being caused by a coronavirus from both symptomatic and asymptomatic patients through droplets and aerosols.
Sorry to interrupt, but please can you switch on your video?
Yes, ma'am.
Go ahead.
Yeah. So this review poster emphasizes on various infection control methods that has been implemented to mitigate the spread of the infection. In which we first deal with the elimination, which reduces the risk of microbial exposure and the disease transmission, which requires a layered approach, of which the first comes the pre-procedural screening, which has led us to the part of teledentistry, which where we screen the persons via the questionnaire system. And second, we move to the pre-procedural testing, where we identify the patients whether they are healthy, infected, or recovered. And next is a pre-procedural rinse, where we use a mouth rinse of 1.12% chlorhexidine, which has been demonstrated efficacy in reducing the microbial load, and which has been stated by Gupta et al. As well as Otto Woodland et al. So Coleste et al. Has also suggested that the use of chlorhexidine before ultra staining has been effective in decreasing the microbial load. And next we move to the dental unit waterline decontamination method, which is also another key step in the controlling the aerosol. So Parmeshlov et al. In 2016 and Antigo et al. In 2020 has suggested the use of pore size of 2.2 micrometer pore filter size, as well as flushing the water lines for 20 minutes has been effective in decreasing the microbial load. And next we move to the high vacuum evacuation, which decreases the aerosol, atmospheric aerosol up to 94% according to the author of Gupta et al. And next we move to the engineering control aids, where we have HEPA filter, which controls and the aerosol production, where it uses of fiberglass fibers, which traps 99.7% particles, which is larger than the size of 0.3 micrometer. Secondly, we move to the negative pressure rooms, which is also known as air pressure isolation rooms, which prevents air from the operatory, that is infected room, to enter into the common spaces. But it has a logistic requirement and associated expenses has limited barriers. Secondly, we have the UV radiations, which is to decontaminate the surface. It is more essential, and we use UVC radiation in the hospital setup to reach the hard to reach areas. And lastly, in the hierarchy of control, we have the prevention, and which includes personal protective equipments and the mask. And it has been graded, and author Apros et al. In 2019 has suggested use of full sleeve gown along with a back closure, which have a maximum protection. So to conclude, the goal of the dental profession is to provide a high quality dental care while continuing to minimize the risk to the staff, patients, as well as the public. Therefore, precautionary principles are to be followed and has to be continued. Thank you.
Good morning. So will you advise the use of all these even after the pandemic ends, or you will go back to your old ways?
No, ma'am. The elimination strategies has to be followed, but substitution categories has its role depending on the practices and as well as the clinicians. But the eliminations and the preventions are to be mandatory, followed even after the pandemic situation.
Dr. Chanchal, you can go ahead with your question.
Can you tell me the recent consensus and the recent where they say that the aerosol of dentistry is responsible for the transmission of the virus? Now, since we are in the COVID times, what is the rate of transmission of COVID-19?
Sorry, ma'am.
Okay, no problem. Thank you. I think this was the end of the presentations that we have for this session. I would sincerely thank Dr. Sylvia for sparing her valuable time this early morning for this poster session. Thank you, Dr. Sylvia. I would request you to please send the evaluation sheet to the email ID as soon as possible. Thank you to all the delegates, and we end the session. Thank you, everybody.
Good morning. We will wait for around 5 minutes until we start the next session. A very good morning and a very warm welcome to all the delegates and judges on behalf of 45th ISP National Conference. So this session will be from the category Review Poster Session 7. So for the session, we have two eminent judges, Dr. Darshan Mundaramani. Sir is currently the Associate Professor as DAP MRV Dental College and Hospital. Sir is also a consultant periodontist and implantologist at Bangalore. Sir is around 40 national and international publications and has attended various national and international conferences. Sir has served as an executive committee member in Indian Society of Periodontology. His areas of interest include intraoral autogenous bone grafting for periodontal regeneration, microsurgical procedures for periodontal aesthetic procedure, specialized skill in periodontal aesthetics, periodontal plastic procedures, and dental implants. Good morning, sir. Next judge for the day, we have Dr. Sumit Malhotra. Sir is presently working as professor and head of the department at ITS Dental College, Ghaziabad, with over 20 years of academic experience. Sir has previously served as principal of Kalka Dental College, Meerut. Sir has multiple national and international publications to his credit and has lectured in many national dental conferences. Sir runs a general dental practice in Noida for last 20 years and also maintains a visiting periodontal and implant practice at Delhi. Good morning, sir. So participants and judges, kindly note, we are completely time bound. So we will be giving a total span of 5 minutes, out of which 3 minutes is for the presentation and 2 minutes is for the question answer session. So sir, shall we commence the session? Okay. So the first poster is RPO 136, Ananya.
Hello, ma'am.
Yes, hello.
Am I audible?
Yes, you're audible. You can proceed.
Okay. Good morning, all. We are here to present a poster on the topic Lifestyle and Periodontics, an advent of bespoke treatment. So this concept was taken from an article by Mark Bartold, which was published in the volume 78 in period 2000. So the traditional periodontal therapy is disease-centered and it usually fails due to the misunderstanding the role of an individual and focusing solely on one-size-fits-all approach or the umbrella approach. So whereas the personalized periodontics have been emerged as an innovative approach that takes into account individual differences in people's genes, lifestyle, environment, and behavior. Henceforth, here the focus is purely on the individual. So first of all, the individual has to be assured that the disease is of sufficient magnitude that warrants action. And the key elements include self-monitoring, goal setting, and planning behavioral change. So the lifestyles to be factored in personalized care model. It includes already established risk factors like smoking and diabetes and other factors like obesity, stress, medication, and malnutrition. Now over to my co-presenter.
Personalized periodontal therapy for those who use tobacco must include systemic and local antimicrobial therapy, host modulation, and customized smoking cessation program. Obesity has been associated with increased inflammatory response, especially pro-inflammatory mediators like tumor necrosis factor alpha, leptin, and pro-inflammatory cytokines. So this highlights the fact that why we have to assess obesity or overweight as a part of risk assessment in an individual. According to Phillips et al., pre-diabetics and early diabetics, if treated, can help in preventing the severity of hyperglycemia and eventually reduce the progression of periodontal disease. So rather than umbrella diagnosis of diabetes, what is more important is understanding the severity of hyperglycemia. The biomarkers of stress, either assessed individually or in combination to assess the allostatic load, will help us to tailor a periodontal therapy, which will not only improve the outcome, but it will also help us to cut the cost of the treatment plan. The effects of the prescription drugs are already well known, while the effects of recreational drugs are only beginning to be recognized. The use of cannabis as well as heroin addiction has been associated with poor oral health, periodontal disease, and caries. So this has to be factored while determining the periodontal health of an individual. Finally, coming to malnutrition. Micronutrients have been associated with biological functions like innate immunity, adaptive immunity, as well as wound healing. So we have to assess micronutrient deficiency while we're assessing an individual during our personalized approach. I would like to conclude by saying that it's high time that we shift our focus from just treating the disease to considering the patient as an individual with the disease and approaching or embracing a holistic approach. The three key elements of behavioral change, which are self-monitoring, planning, and goal setting, can be integrated into the primary care setting so that the patient can be made to recognize and take responsibility for his periodontal health. Thank you.
Darshan sir, any questions?
Yeah, it was a good presentation.
Thank you,
now,
sir.
before the lifestyle changes, what is the role of socioeconomic status for periodontal disease?
Usually people with low socioeconomic status, they do not have proper access to treatment. Also, it can affect their, the nutrient intake can also be affected. So it can lead to, it can affect the periodontal health of an individual. So those with higher socioeconomic status, they have better access to treatment procedures and also better nutrients and better food intake. So that will eventually help them.
Do you mean that only access to treatment will have an effect on periodontal disease progression?
No, so there are, it's actually a multifactorial disease, and there are various factors that are involved in the progression of the destructive periodontal disease. This is just one of the factors that can actually act as an indicator or determinant for the progression of the disease.
Sure. Thank you.
Can we have the next poster, RPO 137? Dr. Kamal? Dr. Kamal, are you there? Okay, I think he's not there. We'll go to the next poster, RPO 138, Dr. Rachana. Dr. Rachana? Dr. Rachana, kindly unmute yourself. We're not able to hear you. Your voice is not audible. Could you please talk a little louder? Dr. Rachana, we are not able to hear you.
Ma'am, am
Yeah,
I
now we
audible
can
now?
hear. Yes. Now we can.
Okay. Should I start with the presentation?
Yes, you can start.
Thank you. Good morning, respected authorities. I, Dr. Rachana Agarwal, and Dr. Anuja Jagtap would like to present our review poster titled HPRF with Enhanced Antimicrobial Activity. So what is HPRF? It is basically the angulation of the tube, that is the horizontal centrifugation of the test tube for the preparation of the PRF. The various other techniques are the fixed centrifugation and the angle centrifugation. So the angulation of the tube plays a major role with respect to the quantity of available growth factors for the better surgical therapy outcomes. So how is PRF obtained? Dr. Joseph Chopin first developed PRF by taking out the blood sample without anticoagulants in a 10 ml test tube and then centrifuging it at 3000 RPM for 10 minutes. And later, the RPM was decreased and the time was increased by the preparation of LPRF. That is, it was decreased to 2700 RPM and the time increased to 12 minutes for the preparation of LPRF. And Ganati et al. Gave a concept of the low speed centrifugation concept for the development of solid and injectable PRFs. That is, the speed of the centrifugation decreases, which results in the increase in the concentration of the inflammatory cells and the growth factors. Centrifugation field is reduced for APRF, APRF plus, IPRF, and they are centrifuged at fixed or angle centrifugation. So HPRF is produced at centrifuging at 700 grams of force for 8 minutes, placing the tube horizontally. In the fixed or angle centrifugation, the platelet concentrates are partially in the blood and partially in the serum, and due to which there is uneven distribution of the platelets. So, but in case of the horizontal centrifugation, the RCF minimum and the RCF maximum are in the same level, due to which the platelet concentrates are available in the increased quantity, increasing the antimicrobial activity. So the antimicrobial activity usually helps in the wound healing by cellular proliferation and migration and release of the various growth factors. They prevent the spread of the microbes by phagocytosis, amplify the complement fixation method system, generate the oxygen metabolite. So basically, the increased platelet concentrate increases the antimicrobial activity. And concluding my poster saying that the horizontal centrifugation produces increased number of platelet and leukocytes when compared to the fixed or angle centrifugation, indicating enhanced healing and antimicrobial activity. Thank you.
Now, does this increase in G-force affect the viability of the platelets?
Sir, actually, the G-force has been increased, from 700 to 208, like in APRF. So basically, it is for the concentration of growth factors, which is released by, especially by the platelets. In our this poster, we have focused on the growth factors, which has been distributed along the PRF, platelet-rich fibrin. So in this, in angled, standard centrifugation machine, we found the most of the growth factors are accumulated in the region of distal part of the PRF. But in horizontal centrifugation, the growth factor seems to be distributed throughout the PRF.
But you are using the entire PRF for the for your purpose, right? Generation purpose. So what is the logic behind it is concentrated in one side and it's not concentrated on the other side? You can use the entire PRF, right? You are using the entire PRF for your procedure.
Yes, sir, but the amount of growth factor, the studies have shown that the amount of growth factor which is seen after the horizontal centrifugation is more as compared with the angle or the fixed centrifugation, sir.
Okay, fine. Thank you.
Thank you, sir.
Thank you, sir.
Thank you. Can we have the next poster, please? RPO 139, Dr. Padmaja.
Yes, ma'am. Should I start?
Yes, you can start.
Good morning, respected delegates. I am presenting a poster on a boost for periodontal regeneration, low-level laser therapy. As we know, laser is a light amplification by stimulated emission of radiation, which was first discovered by Mayman in 1960. Later, the soft laser therapy, that is the low-level laser therapy, first discovered by Endermisser in 1967, which has a wavelength of 600 to 1100 nanometer with the red light or infrared light. It is based on the principle of biostimulation or photobiomodulation, and depending on the electric output, the laser therapies, they are divided into low-level laser therapy and high-level laser therapy. Then when the low-level laser therapy, it acts on the cell, it will stimulate the photoreceptors of mitochondria, and they will cause the release of the nitric oxide, and which will result in the generation of the oxygen-free radicals. These oxygen-free radicals will mainly act on the transcription factor, mainly nuclear factor kappa B and activation protein 1, and they will cause the effects on the wound healing and regeneration and analgesic and anti-inflammatory effect. These analgesic and anti-inflammatory effect will enhance the wound healing and repair process. It has a various clinical applications, out of which I am presenting here two. The effect of low-level laser therapy on the infrabony pocket. Here we can see in the first picture, there is a osseous defect seen with the 4445 region, which was, there was a periodontal abscess which was drained, and after that normal ultrasonic scaling group planing is performed, and after that laser therapy is performed. And after a 12 months follow-up, we have seen there is an increase in the clinical attachment gain, which was 4.5 millimeter. Also, there is a increase in the bone fill by the 37%. In the second case, here we can see the gingivectomy, which is performed with the external bevel gingivectomy by using the Kirkland and Orban's knife, and also by the periodontal BP handle 15 blade. And then the random sites were allocated for which the low-level laser therapy was used. And after a follow, they have seen that there is an increase in the surface epithelialization and complete healing in the laser side, while the control sites there is a slow healing. So to conclude, the ease of use of low-level laser therapy in this increasing technology-based world of research would give a new dimension in the treatment option available for the clinician. Thank you.
Good presentation, doctor. I just wanted to know do you know the mechanism of how this low level laser therapy acts on at a cellular level?
Yes, sir. When the low laser therapy acts on the cell, it will stimulate the mitochondria, and the photoreceptors which are located on the mitochondria, mainly the cytochrome oxidase C. This is the last enzyme of the respiratory electron transport chain, and then this will cause the release of the nitric oxide, which is present in the oxygen deficiency state. When this release occurs, there will be the formation of the reactive oxygen species, and these species will cause their production of the ATP molecules, which is necessary for the cell energy. And also they will act on the transcription factor, and there will be increased production of the hydrogen peroxide, and they will produce the effects on the nucleic acid synthesis, protein synthesis, and increase in the enzymatic activity, and which will improve the cell cycle.
Thank you, doctor.
Thank you, sir.
Can we have the next poster, please? RPO 140, Anindita.
Ma'am, am I audible?
Yes, you're audible. We can start.
Yes. Good morning. I'll be presenting my poster on high hyaluronic acid and dentistry. So what is high hyaluronic acid? Is naturally occurring linear polysaccharide. It was discovered in 1934 by Mayer et al. And his assistant John Palmer. It is found in almost all vertebrate organs, most abundantly in extracellular matrix of soft connective tissues. It has its highest concentration is seen in soft connective tissues, and lowest concentration is seen in blood serum. Now, what are the properties of high hyaluronic acid? It has anti-inflammatory property. It is exogenous. High hyaluronan acts as a scavenger, draining prostaglandins, metalloproteinase, and bioactive molecules. It is anti-eating matters. It is used as an adjunct to mechanical therapy. Healing properties. It is used as an adjunct to mechanical therapy in treatment of periodontitis. Antioxidant, stabilize and the granulation tissue matrix. Viscoelastic properties, it maintains spaces and protects surfaces. Hygroscopic nature, high hyaluronic acid incorporated in aqueous solution. Hydrogen bonding occurs between adjacent carboxyl and N-acetyl group, allowing high hyaluronic acid to maintain stiffness and to retain water. It is biocompatible and non-antigenic. It has bacteriostatic effect, that is reduction of bacterial burden at the wound site, may improve the clinical outcome of regenerative therapy. Now, uses of high hyaluronic acid, it is used in wound healing. It helps in granulation tissue formation. It helps in remodeling of the epithelium. can co-adjunctive treatment in gingivitis and chronic periodontitis. Post-operatively promotes healing for implant and sinus lift procedures, anti-inflammatory properties, minimizes bleeding of probing scores and probing depth. Now, disadvantages: it can cause redness and soreness when injected onto the joints, may cause allergic reaction. High hyaluronic acid can increase eye pressure when injected into the eye. Thank you.
Good presentation, doctor.
Thank
Now,
you.
how do you check for allergic reactions for hyaluronic acid?
I don't know that, sir.
Is there any test?
Yes, so there have been studies conducted. Sir, I'll don't know, sir, actually.
Okay. Now, does you told it is an anti-inflammatory property, has hyaluronic acid has anti-inflammatory property, but during wound healing, inflammation is necessary, right?
Yes, sir.
So how much of it will help and how much of it will inhibit or delay the wound healing?
So mostly 0.12% of hyaluronic acid helps in reduction of inflammation.
Okay.
So that's it.
That's it. Okay, fine. Thank you, doctor.
Thank you.
Next poster, please. RPO 141, Dr. Tripti. Dr. Tripti. Dr. Tripti, are you there? We'll go to the next poster, RPO 142, Dr. Bhavna.
Good morning, ma'am. Am I audible?
Yes, you're audible. We can start.
Yes, ma'am. Good morning, everyone. Today, my poster presentation is on Future of Periodontics, Lies in Artificial Intelligence. Is it a myth or reality? Introduction. The artificial intelligence, or AI, was first coined by John McCarthy, which refers to machines that can imitate human knowledge and behavior. For holistic dental practice, the use of computer-aided diagnosis and treatment plan is gaining momentum, which could eliminate unnoticed human error. And AI models used in dentistry include artificial neural networks, genetic algorithms, fuzzy logic, and convolutional neural networks, and deep learning, all of which could be applied to periodontics. I'm going to discuss about hepatic-based virtual reality periodontal training stimulator and stimulation of ultrasonographic periodontal probe. So the hepatic-based virtual reality stimulator is a prototype dental stimulator for training of periodontal procedures by the use of a virtual reality and haptics technology. The periodontal stimulator allows the trainees to learn performing diagnosis and treatment of periodontal disease by visualizing a three-dimensional virtual human mouth and feel real tactile sensation. It has three phases: the diagnostic phase, the treatment phase, and the evaluation phase. In the diagnostic phase, there's a virtual periodontal probe which through which you can measure the pocket depth and determine the health of the tissues, and in case of pathological situations you can determine the severity. While in treatment phase there's a virtual scaler and the gingiva, there's a two types of gingiva in which there's a transparent gingiva and opaque gingiva. In transparent gingiva you can visualize the calculus C, and in the evaluation phase there's a explorer, virtual explorer, through which you can explore the after scaling you can check whether there's any remnant calculus present. And the stimulation of the ultrasonic periodontal probe, and currently we use a periodontal currently periodontal pocket depth is measured using an invasive manual probe. But adapting diagnostic ultrasound to this purpose can avoid the pain and inaccuracy inherent in manual probing. And 3D stimulation of ultrasonic periodontal probe measurements using a finite integration technique which is adaptable enough to create a realistic anatomical geometric. And I would like to conclude by saying that the studies included above describe that the artificial intelligence is a reliable tool to make a dental care smooth, better, time-saving, and economical for practitioners. And it can also be used to ensure quality treatment, better oral health outcome, and achieve precision. However, artificial intelligence is increasing the scope of increasing the scope of the state of the art models in the dentistry, but it is still under development. Thank you.
Good and innovative idea, doctor. So now everything your concept is based on scanners, right?
Yes, sir. It's based on scanners, sir. And actually, there was a recent study by Lee et al. In 2018, sir. He used convoluted neural networks, sir, for diagnosis and prediction of periodontally compromised tooth, sir, in which they have predicted for extraction for premolars and molars, where the accuracy of extraction for premolars was at 82.8%, while for molars it was 73.4%. And they stated that due to the complexity of the bone loss, bone pattern and loss interpretation in the multi-rooted tooth, hence the accuracy was less compared to the premolar region, sir. And there was even another study by Ferrer et al. In 2018. They have for differentiation between aggressive and chronic periodontitis, sir, and they have used in vector machines for this.
Okay, thank you, doctor.
Yes, sir. Thank you, sir.
Sumit sir, any questions?
It was a nice presentation. Thank you.
Can we go to the next poster, RPO 143, Dr. Nilima? RPO 143, Dr. Nilima. Dr. Nilima, are you there? We'll go to the next poster, RPO 144, Dr. Sharayu. Dr. Sharayu? We'll go to the next poster, RPO 145, Sophia.
Good morning, ma'am.
Good morning. Is this Dr. Sophia?
Good morning, ma'am.
Good morning. Is this Dr.
Sharayu?
Sharayu. Okay.
Ma'am,
Janvi
this
ma'am.
is Dr. Sharayu.
Janvi ma'am, can we go to the previous poster? RPO 144. Janvi ma'am, can we go to the previous poster, RPO 144? There's a slight network problem, so she'll be putting the previous poster. So kindly be online. Janvi ma'am, can we go to the previous slide? RPO 144, Dr. Sharayu. Dr. Sophia, are you there? RPO 145.
Yes, ma'am.
Dr. Sophia?
Yes, ma'am.
Okay, you can carry on with the session.
Okay.
Okay, with the poster here.
Yes, ma'am. A very good morning to all the delegates gathered. Today, my poster presentation is on the topic nanotechnology in periodontics. So, nanotechnology is considered as a new era in the field of periodontics. It is basically the study of smaller molecules, and it involves research and development in the area. And the molecule size of the nanoparticles is less than 100 microns in size. So when one talks about the history of the nanotechnology, it was first discovered by James Clerk Maxwell in the year 1876. And over the years, Kerry Drexler et al., they evolutionized the concept of nanotechnology. So when it comes to the field of periodontics, nanotechnology has got a wide variety of applications. So when we talk about dentin hypersensitivity, one of the most commonly observed clinical problems, the solution for dentin hypersensitivity could be the use of dentifrices, and usually the dentifrices are suffice. But with the advancements in the field of nanotechnology, the dentifrices, that is hydroxy-uptake nanoparticle crystals, can be embedded into the dentifrice, and is found to have very good results against the hypersensitivity problems. Because this hydroxy-uptake nanoparticle mediated dentifrice, it has the ability to cause occlusion of dental tubules and prevent the hypersensitivity. Then we talk about the action against the action from local drug delivery. So this chemotherapy or the local drug delivery, it involves the use of adjunctive medicines for the treatment of periodontal diseases. So in the recent advancement in the field of nanotechnology, the triclosan-loaded nanoparticles has been used. It was first discovered by Pinot et al. In the year 2005, who did a study, and they found that triclosan-loaded particles, it has got a very good effect when it is used as a local drug delivery agent. And when we talk about the triclosan-coated particles, it basically contains nanospheres made up of the L-lactate glycoglycan. And then coming to the dental robots, again, these are small nanorobots which have a very small micron size of 1 to 10. They can be incorporated into the toothpaste or mouthwash, and the dental robots basically they act as agents which swim into the biofilm, and they act against the periodontal pathogens, and they help in the easy removal of the biofilm. And then we talk about the nano implants. Basically, when we place the implant, we have to, the aim of the implant placement is just to have a good osseointegration of the bone surface. And the use of nanotechnology coated particles, nanoparticles, it can help create a surface which achieves a controlled topography and also achieves a very predictable tissue integration. And the nanotite coated implants, that is the Biomet 3i, it has been coated with a complex surface topography by interlocking the newly formed cement line matrix, and also with the nanometer material, which is the DCD, discrete crystalline deposition, and calcium phosphate. The discrete calcium phosphate material has been coated, and the nano implant is also used. And then when we talk about the different other forms of application of nanotechnology in the field of periodontics, it's going to be the electrospun polymer nanofibers. So when we talk about nanofibers, these the fibers are going to be manufactured along the presence of some kind of an antibiotic coated substance for the treatment of various periodontal diseases. And it was found that the application of the nanotechnology in the form of colloidal particles has also been proven effective. And a study done by with Weissa et al. In 2006, they stated that the effective use of the nanoparticles loaded drug delivery system has got very good effect against the in reducing the periodontal pathogens. And another important treatment modality of using nanotechnology is the use of the nanogels.
Dr. Sophia, sorry, your time is up, so we'll have to go to the Q&A session.
Okay, ma'am.
Good morning, Dr. Sophia.
Good morning, sir.
Just a small observation. I think your whole poster is too loaded, you know. So it doesn't give me a clear idea of what you're trying to present. So, okay, so my first question would be, why do you think that nanotechnology has a scope? what does it offer? What was already not there?
Yes, usage of nanotechnology, basically it is the dealing with the smaller molecule size, sir. So we can expect a more precise treatment planning, so while using nanotechnology, like the different methodologies using nanotechnology is also being studied, sir. When it's going to be it is better than the conventional treatment modalities, sir, in certain aspects, like it is better than the conventional treatment modalities, or in certain aspects, like there can be the ease of completion of the treatment, sir, and also the treatment timing can be reduced, because the results can be effectively achieved in much faster way when compared to the conventional procedures, sir. And also the field requires more development and research to be done, so before it is used in larger population cases in our country, sir.
No, that's all from my side. Thank you.
It was a good presentation, Dr. Sophia. Thank you.
Thank you, sir.
Can we have the previous poster by Dr. Sharayu, RPO 144? Dr. Sharayu?
Yes, ma'am. Good morning.
Yeah, participants are kindly requested to keep their videos on during the presentation.
Actually, the virtual background is not that clear.
No, that's fine. That's okay. You can present without it also. Yeah. Dr. Sharayu, you can proceed.
Okay, ma'am. Thank you. So good morning, everyone. Today I will be presenting a poster review on topic chitosan-based nanobioscaffolds in regenerative periodontics. So chitosan, basically it is a naturally occurring polysaccharide extracted from crustacean shells. Conventional method of chitosan scaffold fabrication includes washing, drying, and grinding of crustacean waste. Then it is demineralized, deproteinized, followed by deacetylation process. Chitosan is considered to be a versatile nanobiomaterial as it is naturally available, biodegradable, biocompatible, mucoadhesive, antimicrobial, and non-toxic. In spite of this, it has certain disadvantages like poor mechanical properties, rapid degradation rate, low osteoinductivity, limited water solubility. So to overcome these disadvantages, biocomposite nanobioscaffolds came into the picture where various biomaterials are added to chitosan. Few examples are hydroxyapatite, fibroblast growth factor, transforming growth factor, hyaluronic acid, dicarboxylic acid, BMP6, and bioactive nanoparticles. So key features of this chitosan-based biocomposite nanobioscaffolds are 3D structure provides better cellular structure. It promotes cell migration for periodontal regeneration. It can be used as temporary GTR membrane. It promotes osteogenic differentiation of human periodontal ligament stem cells. It can serve as a carrier for stem cell or used alone to repair bone defects. It can repair periodontal hard and soft tissue defects. So along with this, smart chitosan scaffolds are under development, which displays various adaptable dynamic properties, which helps in easy manipulation and precise placement of scaffold. Along with this, hydrogel and multiphasic scaffolds are in practice, which includes multiple cell layer and multiple materials, along with multiple functionalization techniques. So to conclude, chitosan is emerging as an innovative nanobiomaterial in regenerative periodontics. Combining chitosan-based scaffolds with other nanobiomaterials can widen its application in periodontal tissue regeneration. Thank you.
Good morning, doctor. Are you aware of any chitosan-based products that are already available in the market?
So commercially available?
Yes.
Hello, am I audible,
Hello,
sir?
yeah. Tell me. Commercially available products, do you know any of them?
No, sir.
What is the major disadvantage of chitosan based products?
I will find out.
Okay, fine.
So poor mechanical properties.
Only that?
And also limited water solubility.
That is all what you have already told. Can you
Yes.
elaborate on that? How it will influence your regeneration? Okay, thank you, doctor.
Thank you. I have no questions. Thank you.
Thank you. Next poster, please. RPO 146, Dr. Pooja.
Good morning, ma'am. Am I audible?
Yes, you're audible. You can start the poster.
Good morning. My poster presentation topic is Less is Good, an ode to minimal invasive dentistry. The most commonly opted method to treat the periodontal disease is a conventional surgical technique, which has increased the duration of exposure and increased or excessive tissue manipulation. As the technology advanced, there is new technology, surgical techniques have been evolved to address these limitations of this conventional surgery, and one among that is minimal invasive surgery. This minimal invasive surgery respects health, function, and aesthetic of oral tissues and achieve a goal by ensuring a minimal tissue loss by utilization of small incisions, operating microscopes, and microsurgical instruments and materials to achieve a surgical endpoint. This minimal invasive surgery has an indication. It is indicated in isolated interproximal defects, and it is contraindicated in the cases such as generalized horizontal bone loss and multiple interconnected vertical defects. And it proves an advantage being already which shows an improved healing property, a short chair side time, good patient acceptance is also seen, and disadvantages being technique sensitive, expensive, and it required a specialized instrumentation and it cannot be used universally. There are several techniques, and as shown in the poster, that is modified and simplified papilla preservation technique, pouch and tunnel technique, veil tilt technique, pinhole technique, laser assisted therapy, microscope assisted surgery, and videoscope assisted, and this is a armamentarium employed to perform the minimal invasive dentistry. To conclude, with the technology advanced and the reported advantage of minimal invasive surgical method, it is anticipated to help that would improve the accuracy and dexterity of the surgeon with a minimal tissue trauma to the patient. Thank you.
Good morning, doctor. What do you think are the, Dr. Pooja, what are the advantages you think does the minimally invasive procedures they offer to a periodontal surgeon?
So first of all, there is a very limited tissue manipulation. Lesser area of surgical site will be very small, and there is improved healing, and post-operative pain is also less. And for a surgeon, it becomes a short chair side time also, because area is less, and small incisions are placed, and we avoid vertical incision. We prefer horizontal incisions, and good patient acceptance is also seen. So these are the advantages, and less scarring is also seen. Sorry, sir.
You're in which MDS right now? Which year?
Second year, sir.
So have you attempted any such procedure?
Not as of now. We have not attempted, but in future we would say.
So what are the obvious challenges when you have to practice minimally invasive periodontics?
So we cannot really approach multiple areas and different isolated areas, sir. If it is broader area of action. If we had to perform a surgeries on the broader area, we cannot really go ahead with the minimally invasive.
And do you know about Vista and M-Vista?
Vista, I know, sir, which is a vestibular incision supraperiosteal tunnel access, sir, where it is used for multiple tooth recession coverage with only a single access incision only, sir. This is a Vista technique.
Okay, thank you.
Thank you, doctor.
Thank you, sir.
Can we have the next poster, please? RPO 147, Dr. Mansi. Dr. Mansi, can you unmute yourself?
Yes, ma'am. Am I audible now?
Yes.
Good morning, everyone. I'm Dr. Mansi Lagu, and my topic for poster presentation is the periodontal point of an inflamed joint, that is exploring the relationship between rheumatoid arthritis and periodontitis. So rheumatoid arthritis, as we all know, is an autoimmune and chronic inflammatory disease, which is debilitating in nature, and it is commonly affecting joints of wrist, fingers, knees, temporomandibular joint, and it is prevalent in 1% of the global population. Usually, it affects genetically susceptible older females. So the main event which triggers the formation of autoantibodies is the conversion of arginine residues of peptides to citrulline. This process is catalyzed by endogenously formed PAD enzymes, that is peptidyl arginine deiminase enzymes. So genetic susceptibility, that is individuals with HLA gene DR beta 1 plus environmental factors like smoking, obesity, chronic stress can induce a post-translational modification, giving rise to ACPAs, that is anti-citrullinated protein antibodies, against the citrullinated peptides in the joint synovium. These form immune complexes in the joints, triggering tissue damage, thus giving rise to rheumatoid arthritis. So P. gingivalis is a gram-negative anaerobe which is associated with periodontal tissue destruction, and also it is a prokaryotic organism uniquely found to secrete an enzyme which structurally and chemically imitates the human PAD enzyme. This PPAD spurs or hastens the production of ACPAs in genetically susceptible patients and is also responsible for maintaining the chronicity of the disease. So ACPAs are associated with a higher severity of the disease of rheumatoid arthritis, and also it also shows higher titers of ACPAs are associated with worse periodontal parameters. So in a study published in 2019, it showed that early rheumatoid arthritis was associated with increased periodontitis, that is 60% of the patients preceding the symptoms of rheumatoid arthritis. Since ACPAs are present before the manifestation of symptoms of RA, it has a good predictive value, and they were detected in serum up to 14 years prior to the rheumatoid arthritis onset. So RA leads to loss of manual dexterity, inability to do fine movements, and also the medications of RA, which are steroid based, also culminate in further periodontal breakdown. Oral prophylaxis and maintenance of oral hygiene has shown a dramatic decrease in periodontal disease as well as rheumatoid arthritis parameters subsequently. Although RA is a multifactorial disease, control of the ACPA population in serum is possible via periodontal hygiene, healthy diet, stress control, and smoking cessation. My reference is a systematic review by Hussain et al. In 2020. Thank you.
Good morning, Dr. Mansi.
Good morning, sir.
Whatever reference you told, it was what type of studies they were?
Sir, it was a systematic review and meta-analysis.
No, basically they are all association studies, right?
Yes.
There is periodontitis and there is rheumatoid arthritis.
Yes, yes.
To have a cause and effect relationship, what type of studies should have been done?
Sir, cohort studies.
What studies?
Randomized controlled trials.
That's all from my side.
Okay,
thank you.
Thank you, sir.
Can we have the next poster, RPO 148? Ashika?
Am I audible?
Yes.
Cause effect का relationship वाला कौन सा type का study
Yes,
होना
Ashika, we
चाहिए?
can hear
कौन
you.
सा किया हमने
I cannot
systematic
able
review
to start my video.
तो cause effect वाला तो मैंने बोला cohort cause effect relationship वाला cohort study.
Yeah.
And I didn't say anything. Then I said again randomized control.
Good morning to all. Today my poster topic is a review on bioactive surface coating of dental implants. So dental implants are most commonly used in the field of oral restoration, but there are still many failed implants associated with failed osseointegration, margin port resorption, and peri-implantitis. To overcome this, several physical and chemical modification of the surface of the implants have been done. But still, to improve the clinical efficacy and to improve the antibacterial properties of dental implants, bioactive surface coating of implants came into play. So these are bioactive agents that are applied on the surface of the implants by means of physical absorption techniques like dipping, spray coating, and drop casting techniques. So these bioactive surface coatings are not directly applied on the implant surface. These are encapsulated into the biodegradable materials on the implant surface coatings like natural polymers, synthetic polymers, or inorganic materials. So these biodegradable materials will degrade over the time, will release the bioactive materials into the surface. So there are several surface coating agents are commonly used. So starting with hydroxyapatite and nanocomposite coating. These are most commonly widely used because they have superior properties and non-inflammatory and not immunogenic. So Fang et al. In 2019, he used this hydroxyapatite coating with incorporated with stromal growth cell factor has provided a better osseointegration and biocompatibility. And moving on to the antimicrobial metal coating, so several metals like magnesium has been used. So magnesium phosphate has, because magnesium phosphate mechanical properties are more similar to the normal bone. So Lee et al. Has used this magnesium phosphate incorporated in the epicalecton gallet has shown better osteoblast adhesion, proliferation, and differentiation. It is an in vitro study, and several other metallic coatings also has antibacterial properties like zinc. Zinc also has an antibacterial property, has provided better osseointegration, and copper nanoparticles has also been used because copper has dual role. It has both microbial action and also has a reduce the bone resorptive properties. Next on that is extracellular matrix proteins. Extracellular matrix proteins like chondroitin sulfate collagen also being used as a bioactive surface coating to improve the osseointegration and adhesion, to improve the proliferation and differentiation of osteoblasts. Next to the growth factors, several growth factors also been used. Most commonly used growth factors are vascular endothelial growth factors, bone morphogenic growth factors 2, and some are most commonly studied as a bioactive surface coating of this implant. Next to that is a drug coating implants. So drugs most commonly used drugs are doxycycline. So doxycycline is most commonly used because it has antibacterial action and against Fusobacterium nucleatum, Rhodiola intermedia, and thus it reduces risk of peri-implantitis. So doxycycline incorporated with polylactic glycolic acid used, similar to that amoxicillin incorporated with polylactic glycolic acid has also been used, and several other drugs used in this drug coating coating implants are like titanium nanotubes releasing vancomycin and gentamicin, and like that several drugs have been used. And recently bisphosphonate drugs has also been used to treat osteoporosis patients. So it helps to increase the bone turnover rate and increase the bone density. Next one is that a fluoride coatings. Fluoride coatings, whenever we have treating the titanium oxide surface or implant with fluorides, it improves the properties
Ashika,
of.
sorry, your time is up. So can we proceed to the Q&A session?
Good morning, Dr. Ashika.
Yes.
So I saw a very elaborate presentation again. So, but you know, hello.
Hello.
Am I audible now? I'm sorry.
Yes, sir.
Okay, the most commonly used implant surfaces nowadays do not employ any such coating. Most of the surfaces which we know are subtractive, they have been treated by subtractive methods.
Yes, sir.
So why do you think that is happening?
Sir, these bioactive surface coatings are most commonly we are now using in vitro studies and animal studies, sir, and these are showing some promising results. So it can be one of the recent advances in the field of implantology.
In the previous era, there have been a lot of implants which were plasma sprayed by hydroxyapatite, but then it was discontinued for a reason. Do you have any idea why?
No, sir, I will find out.
Okay. Thank you so much.
Thank you, sir.
Thank you, doctor.
Thank you, sir.
Can we have the next poster, RPO 149, Ranjana?
Yes, ma'am. A very good morning to everyone. I'm going to present the review poster of minimally invasive parental surgery. This minimally invasive surgery is defined as the ability to perform the traditional surgical procedure and achieve the better outcomes with the surgical opening that was smaller used in the traditional surgical access. And the indications are there are usually isolated defects we can use, an interproximal defect that will not extend beyond the interproximal state, and the defect that extends to the buccal or lingual from the interproximal area, and the periodontal defect that borders on edentulous areas, and the multiple separate sites within a single quadrant. The contraindication of these techniques are a generalized horizontal bone defect and multiple interconnected vertical defects or walls. There are several techniques in this minimally invasive parental surgery. That is simplified papilla preservation technique, modified papilla preservation technique, and pinhole technique, buttonhole technique, and vestibular incision subperiosteal analysis technique, and videoscope assisted minimally invasive surgery. I have shown some of the techniques here. They have shown a pinhole technique and the modified papilla preservation technique and simplified papilla preservation technique. In modified papilla preservation techniques, we can use with greater than 2 mm of defect. In simplified papilla preservation technique, we can use with less than 2 mm of the defect. In this, the decision making was given by Stephen K. Harrell, and he gave 4 notes. It's Note 1 is surgical assess, Note 2 is the flap design, then Note 3 is regenerative strategy, and Note 4 is how to suture. Then I have given the vestibular instance appearance tunnel access. In this, we can coverage the multiple decision defects with the single incision. We can use either with the PRF or collagen membrane. Then have shown the buttonhole technique, then videoscope assisted minimally invasive surgery. These surgeries have better advantages because they will decrease the tissue manipulation that lessens the overall trauma to the surgical sites, and it permits the faster healing and perform with small incision. So lingual aspect without extending to the healthy tissue, and there will be reduced patient morbidity and chair time, and the post-operative gingival restriction is minimum, and we can use with loops, microscopes, and microsurgical instruments.
Doctor?
Yes, sir.
What is, if you are using the minimally invasive procedures, what is the inherent disadvantage that it has?
Sir, what is the
inherent disadvantage that minimally invasive periodontal surgical procedures have?
Sir, it cannot be applied universally to all the procedures, sir. Then this technique is very technique sensitive, and we can use only microsurgical. Improved instrumentation is to be needed, sir.
What is the basic concept of flap surgery?
So basic concept of flap surgery is to eliminate the granulation, is to remove the deposits and characters present in that area, and any granulation tissues to be depleted in that area, sir, and to enhance the tissue resilient and firmness.
Okay. Thank you, doctor.
Thank
That's
you.
all from me.
Thank you. No questions.
Can we have the next poster, please? RPO 150. Shweta.
Yes, ma'am. Am I audible?
Yes, you are audible. You can start with the poster presentation.
Okay. Good morning. The topic of my review poster is Nano Steps into Periodontology. Nanotechnology is a technology on a nanoscale. It is the creation and utilization of materials, devices, and systems through the control of matter on the nanometer scale. The properties of nanomaterials are it contains constituents less than 100 nanometer in minimum one dimension. They have significant surface size, quantum effects, and show better performance properties than traditional materials. They have special chemical, optical, magnetic, and electro-optical properties. They can self-assemble by which they autonomously organize themselves into patterns or structures without any intervention. Coming on to classification of nanomaterials, according to origin, it is divided into natural and synthetic. According to composition, it is classified into organic and inorganic. According to dimensions, it can be classified as 0, which has no dimension, which includes quantum dots and nanoparticles. 1 dimension includes nanotubes, wires, and rods. 2 dimension includes thin films, plates, and layered structures, and 3 dimension includes liposomes, dendrimers, and polycrystalline structures. According to structure, it is divided into liposomes, dendrimers, carbon-based, and metal-based nanomaterials. According to generations, there are 4 generations, in which first is passive, which involves steady function nanostructures like non-invasive diagnostics. Second is active, which involves evolving function nanostructures like targeted cancer therapies. Third includes integrated nanosystems like artificial organs built from nanoscales. And fourth includes heterogeneous nanosystems, which includes nanoscale genetic therapies. Then there are 2 approaches for manufacture, which are a top-down and bottom-up approach. Top-down is by which large materials are converted into smaller ones, and these are further manipulated to form nanoparticles. This approach is used in the development of nanoparticles, nanocomposites, nanoneedles, etc. And bottom-up approach is done by uniting atomic level substrate through ionization of energy from various sources. This approach is used in local anesthesia, hypersensitivity cure, and nanodiagnosis, etc. The different nanomaterials are quantum dot, nanoparticles, nanorods, nanotubes, nanofilms, wires, nanoscaffolds, films, liposomes, nanoshell, polycrystalline, dendrimer, and nanorobots. The advantages of nanotechnology are it can be used in prevention using antibacterial agents like silica, silver, copper, etc., and as surface coatings, and also for oral hygiene maintenance. Diagnosis using nanopores, tubes, and nanoplasmic sensors. Restoration using nanocomposites, nanosolutions, nanoencapsulation, etc. Regeneration using bone grafts, tissue engineering methods. Rehabilitation, anesthesia using nanorobots, and for treatment of cancer. The nanotoxicities are, there is no standard protocol for use. Biodegradability of nanomaterials is unsure. Chemical composition, surface charge, solubility can vary with the environment. Nanohazards that can occur, it may occur due to accidental or involuntary contact, interference with cell signaling, unwanted effects of DNA, and challenges faced by nanotechnology comprises of engineering, biological, social, and ethical challenges. Future of nanoperidontics depends on the usage of nanotechnology in drug delivery, gene therapy, cell surgery, molecular signaling, and patient-specific treatment. Thank you.
Good presentation, doctor.
Thank you, sir.
What is the major advantage and disadvantage of nanotechnology?
Major advantages, it can be used in various procedures, like tissue engineering can be involved in nanotechnology and can be used for restoration, and bone regeneration can also be done. And the disadvantages, it can cause hazards like DNA modulation can occur, and it can cause injury to patients, and accidental swallowing of nanomaterials can occur. And standard protocol for use is unsure, sir, till date. It is still under research, sir. There is no standard protocol.
Okay, thank you, doctor.
Thank you.
Thank you. I have no questions.
Yes, sir.
No questions from my side. Thank you.
Okay, sir. Thank you.
Next poster, please. RPO 152, Kavya.
Am I audible now?
Yes, Kavya, you're audible.
Yes, ma'am. Good morning, all and all. Today, my poster topic is geriatric perodontology and how it influences the future dental profession now. Geriatric population are people who are aged 65 years and above, and they count about 11% of total world's population. And by 2050, this geriatric population is expected to increase to about 22% of population. In the developed world, with the focus on prevention of oral diseases, has led to increase in the number and percentage of older adults who are retaining teeth for their lifetime. And this emphasis on the tooth retention has led to decrease in the edentulosum. And in the periodontal aspects, this decrease edentulism has led to increase the rates of severe forms of periodontal disease. And coming to the in terms of dental care for the older people, there exists a link between the periodontitis and their dental caries. The severity of the periodontal disease increases with the age, and this periodontal disease associated with the gingival recession will make the tooth roots exposed to the oral cavity, and thereby making them highly susceptible for caries, and ultimately leading to tooth loss. So this retention of the tooth is an in the older population is linked to a better quality of life. And another important consideration of the older population in terms of a dental care is the increased prevalence of non-communicable disease in this population, and it is according to WHO study in 2008, 60% of people worldwide die from non-communicable disease, and it is expected to increase to about 70% by 2030. So the people who visit the dental office, the older people or may be affected from one or more of the non-communicable disease, and there exists a bidirectional pathological interaction between the periodontitis and the non-communicable disease. So the patients, these patients with the non-communicable disease tend to take in multitude of drugs for their non-communicable disease. So the healthcare professionals, the oral healthcare professionals must provide, must have a knowledge and should have increased level of communication with the other healthcare practitioners. So why we need to have interprofessional practices, because we can identify whether the patients require any modifications in their oral care, and to implicate the oral findings on the systemic disease, and the impact of the systemic diseases on the oral diseases can be implicated. Hence, the focus is now on the interprofessional health education with the goal of providing interprofessional practice. So this is obviously benefit for both the practitioners and the patients. For the patients in terms of better health and oral health outcomes, and for the oral healthcare providers, there will be improved patient management. So this change in the dental profession should be centered on the oral adults, and geriatric pedontology is the most logical phase for the transformation to begin with.
Yeah.
Thank you.
Good morning, Dr. Kavya.
Good morning, sir.
Can you, or do you know the classification of aged people? How old people are classified?
The oldest people are classified as more than 65 years of age are called as elderly population.
Young, old, young, old, and old. Do you know the ages?
Yes,
okay, fine. Now, what are the things to be considered when you are managing the aged individual?
Sorry, sir?
In brief, if you can, what are the things that has to be taken into consideration apart from the medical health or general health? What else you have dentally? What all things you have to consider when managing the old age?
Old age people, the utmost goal is to provide them with the teeth which is most functional. They need to have at least 20 teeth for the successful aging. So we need to provide them with good oral hygiene. We need to reinforce the oral hygiene procedures and make them available for it. And also, in case of periodontally, there should be minimum of only 4 mm of pocket that need to be present.
Thank you, doctor.
Thank you.
Sumit sir, any questions?
No, I have no questions. Thank you.
Okay, can we have the next poster, RPO 153, Dr. Ruchi?
Yes, ma'am, am I audible?
Yes, doctor, you can proceed.
Hello, ma'am.
Yes, doctor, we can hear you. You can proceed.
Ma'am, I'll start.
Yes, start.
Good morning, everyone. I'm Dr. Ruchi Yasota, and I'll be presenting a review poster on nanotechnology with respect to bone regenerating nanomaterials and nanostructured coated implants. So nanomaterials are organized natural extracellular matrix, and they generate functional bone tissues through osteomimetic nature. Basically, nanomaterials, they mimic the osteoarchitecture. So now coming to bone regenerating biomaterials. So bone tissue represents a biological nanocomposite composed of organic, that is collagen type 1, and inorganic nanocrystalline hydroxyapatite components. So the structure of nanomaterials, they allow protein to get entrapped inside the meshes of a gel, promoting a biomaterial driven bone regeneration, exchange of nutrients, and they are released when required. So nanomaterials is a popular bone substitute coating and filler material since it promotes mineralization. The nanocomposite grain sizes have high surface fraction of grain boundaries, and they increase the osteoblast function. So for application, synthetic and natural polymers like PGA, PGLA, PLLA, PLA, gelatin, chitoskine are excellent candidates for bone tissue regeneration through their biodegradability and ease of fabrication. So we can appreciate the structure between the nanohydroxyapatite crystals and the commercially available hydroxyapatite crystal. So indication of nanomaterials are in intrabony defects, socket preservation, sinus augmentation, and GBR procedures. So commercially available is Vitos, where whose size we can appreciate, that is 1 micron as compared to the size of a 20 micron osteoblast, and the commercially available size of a bone regenerating material is 10 microns. So now coming to nanostructured coated implants. So inadequate bone formation around implants and osteo integration, they are exacerbated by microbial infection, and thus they are a reason for implant failure. At nanoscale, receptors of the cell membrane, such as integrins, they distinguish absorb proteins on the surface, which is in turn controlled by the nanostructure on the surface itself. So epithelial cells, osteoblast cells get more easily attached to the rough surface, similar to found on the commercial implants when treated surfaces. Nanotechnology can fabricate a new generation of implant materials with high efficiency, low cost, and high surface area to volume ratio. Nanoscale features are the increase in adhesion and colonization of the cell, extracellular matrix formation, decrease in healing time, increase in osteoregeneration, and nanostructured hydroxyapatite crystal, titanium nanotubules, silver laced nanoparticles are used. So coming to the radiograph, where we can appreciate the titanium and calcium phosphate, which show direct bone apposition of calcium phosphate coated implants on like the nano materials. Thus, to conclude, nanoscale alteration of titanium implant surfaces alter cellular and tissue responses and promote osteo integration. So bone growth and implant success could also be accelerated with the help of nanotechnology. Thank you.
Good presentation, doctor.
Thank you so much, sir.
If nanotechnology is found to be so much advantageous, you
Yes.
have told so much about nanotechnology. Why is it
Yes,
still
sir.
not in use?
So because of so there is also a risk where the nanotechnology debris can affect the humans. So hence there is less study evidence to prove so. And ideally saying, sir, the materials used in nanotechnology, they are way too expensive for the patients as well. So there is a need for materials which are effective yet at a cheaper price, where the treatment can be accepted, like the treatment material provided to the patient can be acceptable.
Okay, thank you, doctor.
Thank you, sir.
No questions from my side. Thank you.
Thank you, sir.
Can we have the next poster, please? RPO 154, Dr. Yashasri.
Ma'am, am I audible?
Yes, doctor, you're audible. You can proceed.
Yeah. Good morning, everyone. Ma'am, shall I start?
Yes, you can start.
Good morning, everyone. My topic is impact of vape pens on periodontitis. So giving a brief intro, in recent years, e-cigarettes have been gaining popularity. The main purpose of invention of e-cigarettes was to replace the conventional cigarettes for helping in smoking cessation. However, its safety and how it affects the periodontal health is still debatable. E-cigarettes was invented in the year 2004 by Mr. Hon Ling, a Chinese scientist. Now, what is e-cigarette? How does it work? What are its components? E-cigarettes are the battery-operated devices that heat a nicotine-containing liquid to produce an aerosol, which is inhaled. It has components such as battery, it has a LED, microsensor, and a heating element, and also a cartridge that heats an e-liquid. This e-liquid is comprised of propylene glycol, glycerin, nicotine, and other flavoring agents. Apart from this, there are also trace elements released which have health effects such as periodontal effects. The trace elements are cadmium, aluminium, aldehydes, carbonyls, etc. So these aldehydes and carbonyls, they cause the autoantibody production, which will lead to DNA damage, which in turn leads to destruction of matrix and bone loss during periodontitis. E-cigarettes containing nicotine also affects oral myofibroblasts, and also they have the effect to effect on the wound healing ability by decreasing the wound contraction. This is due to release of matrix metalloproteinases 9, 12, and prostaglandin E2. So apart from this, there is a study conducted in the year 2010 by Bartel et al. He concluded that there is a decreased bone to implant contact in rats who has taken subcutaneous nicotine. So next, coming to the adverse effects of e-cigarettes in this image, although they have a significant impact on cardiovascular, cellular, and respiratory effect, but they are favorable and lesser effects when compared to conventional cigarettes. So hereby I conclude that e-cigarettes are less harmful than conventional cigarettes, but they still can contribute to the pathogenesis of periodontal diseases such as impaired ability, repairability, cellular injury, and inflammation. So further research is needed in order to establish the risk of using e-cigarettes. Thank you.
Good morning, Dr. Yashasri.
Good morning, sir.
What are the acceptable nicotine replacement therapy methods as of now?
Sir, electronic nicotine delivery systems such as vape pens, Joule pods.
Any other methods you know of?
Any other methods?
Have you heard of any toothpaste which contains tobacco?
Toothpaste containing tobacco.
Okay, that's all from my side. Thank you.
Thanks.
No questions, doctor.
Hey, Usman. Sir, you come and answer. Dabur Red Plus, sir.
So Dabur Red does not contain tobacco. Any
Okay,
other?
sir. Sorry, sir. I'll find out, sir.
Thank you.
Yes, sir. Thank you, sir.
Can we have the next poster, please? RPO 155, Dr. Ajay.
Good morning, ma'am.
Good morning.
Ma'am,
Good morning, doctor. Yes, you can proceed. We can hear
my
you.
topic for poster is effectiveness of tetracycline group of drugs in the treatment of peri-implantitis. A systemic review and meta-analysis. Peri-implantitis is defined as inflammatory process that affects the soft tissue surrounding the osteointegrated implant with concomitant loss of surrounding marginal bone. Tetracycline group of drugs are primarily bacteriostatic antimicrobial. They exert their antibacterial activity inhibiting microbial protein synthesis. The purpose of the study is to systematically review the literature to assess the effectiveness of tetracycline group of drugs in resolution of peri-implantitis. The present systematic review was registered in Prospero. It was developed and conducted using Prisma flowchart 2009. Overall studies identified over 96 using different databases. After screening and removing duplicate studies, the number was 74. After full text assessed for eligibility and inclusion criteria, only 6 studies were found, and that was one was surgically treated. So overall, after all analysis, only 5 studies were included in systemic review. Inclusion criteria: patient diagnosed with periimplantitis with peri-implant bone loss 0.5 to 2 mm, probing pocket depth was 4 to 6 mm, and the age group was 18 years and above. Only randomized control trials were included. Exclusion criteria: present of medical condition that affect peri-implantitis and treatment procedure and non-RCTs. Risk of bias: overall risk of bias was had some concerns. A description of
Dr. Ajay? Sorry, you're not audible. Dr. Ajay? Sir, should we proceed to the next poster?
We'll give it another 30 seconds. If it doesn't join back, we'll proceed.
Okay, sir. Yes. So, shall we go to the next poster? I don't think he is online.
Sure.
Yes. So, can we go to the next poster, RPO 156, Dr. Kasturi?
Yes, ma'am. Good morning, ma'am. Ma'am, can I start?
Yes, you can start.
Okay. Good morning, everyone. The topic for my poster presentation is proteomics in periodontics. Proteomics is a study of all proteins, including their relative abundance, distribution, post-transcription, translational modifications, functions, and interactions with other macromolecules in a given cell, at a given environment, and a specific stage in the cell cycle. The word proteome is actually a combination of the words protein and genome and was coined by Mark Wilkins in 1994. Moving on to the omics cascade. The word omics basically means analysis of large amounts of data representing an entire set of molecules of a similar kind. So, genomics is a sum total of genes. Similarly, transcriptomics is a total of RNA. Proteomics is a total of proteins, and metabolomics is a total of metabolites. All these determine the phenotype of a person in health and disease. Proteomics relies on three basic technological cornerstones that include: first, a method to fractionate complex proteins or peptide mixtures; second, mass spectrometry to acquire the data necessary to identify the individual proteins; and third is bioinformatics to analyze and assemble this data. Basic proteomic approaches include the bottom-up and top-down proteomics. In the bottom-up proteomics, it provides an indirect measurement of proteins through peptides derived from their digestion, whereas in contrast, in top-down method, it measures the intact proteins. Moving on to the types of proteomics, as the name suggests, structural proteomics attempts to identify and determine the structure and location of proteins. Functional deals with the functions of these proteins, and interactional proteomics characterizes all protein interactions. The use of proteomics in periodontics is in various fronts, which include the detection of onset, progression, and the effect of treatment by detecting various biomarkers present in saliva and GCF. In a recent study done by Sorsa et al., it was found that the presence of biomarker MMP8 in periodontitis patients may also detect the potential risk and severity of COVID-19 infection. Presence of MMP8 activated MMP8 in oral fluid is analogous to the presence of CRP in the serum, which gives the total anti-inflammation present in the body. Periodontal pathogens can degrade the basement membrane components and activate the pro-MMP, which leads to systemic spread of infection. Commonly used drugs in periodontal practice like chlorhexidine and doxycycline can inhibit activated MMP8, and this was the highlight therapeutic importance of this study. Thank you.
Okay. Good presentation, doctor.
Thank you, sir.
You told it is similar to CRP in the oral cavity, right?
Yes, sir.
What type of indicator is CRP? Whether
So
it is specific or non-specific?
It is a non-specific indicator of the oral in the body.
Okay. So whereas MMP8, activated MMP8, is it specific or non-specific?
It is specific, sir. It is specific for periodontitis.
It is specific for periodontitis. Yes. So how do you correlate between activated MMP8 and CRP?
Sorry, sir.
How do you correlate between MMP8 and activated CRP?
Activated MMP8 is a specific marker, and
Yes.
it is also in other systemic conditions like diabetes, or in cases where patients are treated after oral cancer patients. So in case of CRP, it is non-specific and it gives the overall inflammation value of the body. It is a MMP8 is a more specific value.
Fine. Thank you.
Sumit sir, any questions? So shall we proceed to the next poster? The next
we can proceed.
Okay, sir. Next poster is RPO 157, Dr. Sandeep.
Yes, ma'am. Good morning to all of you. The topic of my topic of presentation is the prevalence of periodontal disease among tribal and non-tribal population, a systematic review and meta-analysis. The tribal population globally experience poor health than the non-tribal counterparts. Globally, the occurrence of periodontal disease such as gingivitis and chronic periodontitis are high among tribal peoples. Due to various barriers to assessing dental care with the social and economic disadvantages, tribal have a higher disease burden compared to the non-tribal populations. The objective of this review are to quantify the prevalence of periodontal disease among tribal population compared to non-tribal population at a global level, and to analyze the documentation of the burden of the periodontal disease that persists in tribal community worldwide. Under methodology, using keywords and the appropriate mesh term across several databases, capturing published and unpublished articles are searched. This review will consider and compare the studies that have reported prevalence of periodontal disease among tribal and non-tribal population. Random effects meta-analysis of the observation data was conducted from selected studies. Under methodology review, the complete protocol follows the review questions, including criteria, outcomes, search strategy, assessment of methodological quality, data extraction, and data synthesis. Coming on the result, the proportion of the periodontal disease is more than 87% in the tribal population as compared to non-tribal population. And the moderate to severe periodontitis is a common periodontal disease in the tribal population as compared to non-tribal populations. So the prevalence of periodontal disease based on loss of attachment is more. And the loss of attachment with the gender group is more common in the male compared to females. And the prevalence of periodontal disease based on this page, the calculus is the main factors which raise the periodontal disease in tribal population as compared to non-tribal population. So my conclusion is tribal population has a high prevalence of periodontal disease than non-tribal population at global level. Burden of periodontal disease that persists worldwide in tribal community has been conclusively analyzed and documented. Thank you.
Good presentation, doctor.
Sir, thank you, sir.
Uh, there is one thing regarding what are the tribal, are there any practices in the tribal areas which will or which influences the parental health in a positive way, that even though they don't have access to oral health care, are there any practices? Did you find any practices?
Yeah, yes, sir. In commonly, the tribal people is commonly allowed in the dense forest area, the forest remote areas. Most commonly is lived in the remote areas. So they don't have the very advanced and the dentifrices powders based in they have not communication properly for getting this good advanced toothpaste to dentifrices for taking the regular brushing. So they have most commonly used the coke powders at the local levels, and secondly they burn the wooden sticks and use for the brushings. Then they also take some nimbu sticks, the lemon sticks, for getting the brushing in day-to-day practice. So these are one of the Ayurvedic measures to maintain his oral hygiene only due to the non-access of the proper dental cares in the remote areas.
Okay. Thank you, doctor.
Thank you, sir.
Sumit sir, any questions? Okay, we'll go to the next poster. RPO 158, Dr. Apeksha.
Yes, ma'am. Good morning, everyone. The topic of my poster is regenerative therapies in aggressive periodontitis patient. So, as we all know, aggressive periodontitis, it is a type of periodontitis wherein there is a rapid destruction of the periodontal ligament and alveolar bone, which occurs in otherwise systemically healthy individuals who are generally of a younger age group, but patients may be older as well. So even though the prevalence of aggressive periodontitis is much more lower than that of the chronic periodontitis patients, the management is still challenging because of its strong genetic predisposition, which is an unmodifiable risk factor. Hence, various modalities have been employed for the periodontal regeneration, which include the use of bone replacement grafts, the barrier membranes, or the guided tissue regeneration, biological modifiers such as growth and differentiation factors and extracellular matrix proteins like the enamel matrix derivatives, or use of a combination of above techniques and materials which have been extensively reviewed. So each of these materials have their own advantages and disadvantages. So here in the first picture, they have used the GTR as well as demineralized bone xenograft. And they have observed that there is an increase in the parameters, like there's a reduction in the pocket probing depth as well as the clinical attachment loss. Same was seen in the case where they have used a combination of the enamel matrix derivatives as well as bovine bone matrix. And in the third picture, the defect was treated using the PRP and the hydroxyapatite. There also they have seen that there is a reduction in the clinical attachment loss, the pocket probing depth, as well as there is an increase in the bone gain. So there are also studies which have compared the surgical treatment options with and without the use of biomaterials, and they have concluded that use of biomaterials for the regenerative therapies in aggressive periodontitis may be more effective than just the surgical debridement alone. So thus to conclude, multiple regenerative strategies are effective in achieving the periodontal regeneration in the intrabony defects. With increasing loss of height, the proximity and number of remaining bony walls, there is a greater need for combination therapies to achieve the predictable periodontal regeneration. Thank you.
Good presentation, doctor.
Thank
Which
you,
year
sir.
are you in?
So right now in second year.
Second year. How many have you managed any aggressive periodontitis cases? Rapidly progressing?
So far, nothing, sir.
Not yet. Okay.
No, sir.
So, thank you very much.
Thank you, sir.
Sumit sir, any questions? Sumit sir? Thank you. So actually with this we are done with the posters. But however, there were few poster sessions which were missed out by the participants. So I would like to call out their numbers. First was RPO 137, Dr. Kamal. Are you there? RPO 137, Dr. Kamal. Okay, then the next number was RPO 141, Dr. Tripti. RPO 141, Dr. Tripti. And the next was RPO 143, Dr. Neelima. Dr. Neelima, are you there? Okay. So with this, we have come to an end of the session. Sumit sir, Dr. Darshan sir, I would like to thank you for sparing your valuable time, and thank you to all the participants.
Yeah, thank you very much, Doctor.
Thank you, sir. And I would like to kindly request the judges to mail their completed evaluation sheets to the mentioned email ID, that is poster.ispconferencepune@gmail.com. And the next session will be held at 12 p.m. by Dr. Sarika. So thank you and have a good day.
Thank you.
Thank you, sir. Thank you. Thank you, Sumit sir.
Good afternoon, everyone. We will just take a couple of minutes. Rakesh sir has to join in, so we'll just wait for him to join. So we can begin our session. Dr. Rakesh has joined us. A very good afternoon to one all present here. On behalf of the organizing and the scientific committee of the 45th ISP National Conference, I welcome you all for the afternoon session. Chairing this session today, we have Dr. Chaitanya Adurti. Sir has done his periodontics and implants from Sibar Institute of Dental Sciences, Vijayawada, Andhra Pradesh. Sir has a lot of national and international publications to his credentials. Along with Dr. Chaitanya, we have Dr. Rakesh Mutha. Sir is an associate professor in D.Y. Patil Dental College, Dental School, Pune. Sir has won the prestigious S.G. Damle Gold Medal Award in 2009. Sir also has international and national publications race credentials. I welcome you both, sir. So with this, we can begin our first session of the review poster. Can we have the first presenter?
Bye-bye. Thank you.
Hello. Good afternoon, ma'am.
Good afternoon.
Yes, sure. Okay. Today, my topic is on oral mucormycosis, a threat to COVID patients from the desk of periodontitis. Introduction: a recently emerged complication, a rare fungal infection called black fungus, is caused by a group of fungi called mucormycosis. Black fungus in COVID-19 patient is increasing due to immunodeficiency states like diabetes, malignancies, hemopoietic disorders, poor oral hygiene, and immunosuppressive drugs. Maintaining oral health is of utmost importance to prevent the spread of such infections. Most common type of oral mucormycosis is being a rhinomaxillary disease. So here is a postulate interaction of the diabetes, corticosteroid and a COVID-19 with mucormycosis. Here, in this, we can see the patient with the pre-existing diabetes mellitus or patients on the corticosteroids have an increased in the chances of getting infected with the mucormycosis, with increase in uncontrolled diabetes mellitus and leading to diabetic ketoacidosis, which decreases the CD4 cells and the CD8 cells and increases the reactive oxygenous species and ferritin, which leads to mucormycosis. Most common type of mucormycosis is being the rhinomaxillary disease, in which the patients might report primarily to the dental practitioners with the dental pain, mobile teeth, halitosis, purulent discharge resembling chronic generalized periodontitis, aphthous ulcers, candidiasis, palatal ulceration, and angular cheilitis. So the early radiographic imaging and diagnosis is helpful in assessing the extent of involvement of this fungal disease, which requires prominent aggressive treatment. Some of the radiographic finding we can see as a black turbinate. Black turbinate is nothing but a lack of enhancement of nasal turbinate on MRI imaging. And it also leads to mucosal thickening, bony erosions, sequestrated bone, and fluid-filled sinuses. Here you can see a case of mucormycosis with the fluid-filled sinuses and a sequestration of right maxilla. Some of the differential diagnosis for COVID for oral mucormycosis is due to trauma, infections, neoplastic, and collagen vascular diseases. Coming to the conclusion, global pandemic has created a black hole in everyone's life. Hence, self-awareness is important. We as periodontists emphasize that mucormycosis should be included in differential diagnosis whenever a patient visits with symptoms of periodontitis. Thank you.
Thank you, Doctor. Chaitanya, Lucky sir, questions, please.
Yeah, very good presentation. Am I audible?
Yes, sir. Yes, sir.
Yeah. Miss, what would be the role of a periodontist in these cases? The cases of mucormycosis?
Yes, sir. We can. Many of the after COVID patients report with a chronic generalized periodontitis cases with the halitosis and purulent discharge. We can manage with that.
Okay, fine.
Am I audible?
Yes, sir.
Yeah, it's an excellent presentation. Your poster is also very nicely representing all the pictures.
Thank you, sir.
So, which form of mucormycosis is most common in the orofacial region?
Rhinomaxillary sinus is most common in this, sir. Here we can see a patient reporting with multiple aphthous ulcers, resembling like chronic generalized periodontitis with dental pain, halitosis, or this kind of.
What are the radiographic features we can see?
Here in the radiographic, sir, mucosal thickening can be seen, sir, and black turbinate, which is a lack of enhancement of nasal turbinate on MRI imaging we can see, and bony erosions and sequestrated bone can be seen here.
Very good.
Move on to the next presenter.
Yeah.
Thank you.
Thank you, sir. It's a request for all the participants to mute yourself, please. Thank you. Can we have the next presenter?
Good afternoon, ma'am. Am I audible?
Yes, please. Please begin.
Good afternoon, everyone. Topic for my today's presentation is nanohydroxyapatite in periodontal surgery. Hydroxyapatite is a calcium phosphate compound having a calcium to phosphate ratio of 1:67 with molecular formula C18PO46OH twice. Nanohydroxyapatite particles of size between 50 to 100 nanometers have considerably higher surface area, enhancing protein adsorption and binding. It has various uses in dentistry, like it is used in dentifrices. It is used as a coating material for oral implantology. It is used in management of dentine hypersensitivity, in bleaching, in periodontal regeneration, and in restorative dentistry. Nanohydroxyapatite has many successful outcomes, which are as follows. Firstly, osteoblast stimulation. Nanohydroxyapatite could bind to the bone and stimulate the osteoblasts in early stages of periodontal defect repair, according to Schnettler et al. 2004. According to Detz et al. In 2010, nanohydroxyapatite with low or no carbonate content can enhance the differentiation of osteoclast-like cells into osteoblast-like cells. According to Saleh et al. In 2014, and nanohydroxyapatite could enhance fibroblast cell maturation and proliferation, resulting in connective tissue regeneration. According to Bing Du et al. In 2015, neovascularization within the early stage of bone healing could be increased by nanohydroxyapatite coralline blocks coated with recombinant human vascular endothelial growth factor. According to Bamam, 2020, sites retreated with nanohydroxyapatite showed highest increase in joints. According to Wang et al. In 2020, the nanohydroxyapatite modified collagen biomimetic composite material combined with GTR could promote the growth of new alveolar bone and new cementum and prevent epithelium ingrowth into the defect site. According to Liao et al. In 2021, the nanohydroxyapatite chitosan scaffold could inhibit the growth of periodontal pathogens. So coming to resorbability of nanohydroxyapatite, its complete resorption takes 12 weeks. Hence, it is appropriate for post-extraction socket preservation. Hence, in conclusion, nanohydroxyapatite is a propitious biomaterial for various periodontal surgical interventions. Its physical, chemical, and mechanical properties make it one of the most promising synthetic materials for modern dental medicine. Thank you.
Thank you, Dr. Samriti. Sir, questions? Chaitanya, sir?
Yeah. So you had told about the stimulation and proliferation of the periodontal ligament fibroblasts, right?
Yes, sir.
So can you tell how this nanohydroxyapatite will enhance those stimulation and proliferation of fibroblasts?
Sir, due to the higher surface area, it enhances the binding of proteins. So more of the cells are stimulated.
Is there any action of BMP2 here?
Yes, sir.
So what is the action of the release of growth factors by this nanohydroxyapatite? What is the added benefit of adding nanotechnology to the hydroxyapatite previously used?
Sir, it increases the surface area and the particle size is smaller.
Yeah. So what happens if the particle size is smaller and surface area is increased? What about vascularity? Is there any increased vascularity?
Yes, sir.
It's a good presentation.
Dr. Rakesh?
Yeah. Good presentation, Samruddhi. You said that hydroxyapatite resorbs completely in 12 weeks, right? Do you have any studies supporting that hydroxyapatite resolves completely?
Yes, sir. I had read an article. I don't remember it right now.
Okay, fine.
Thank you, sir. We'll move on to our next presenter.
Thank you.
Dr. Saurabh? Dr. Saurabh, am I audible? Dr. Saurabh, are you there in the meeting? We have unmuted you, Dr. Saurabh. Rucha, can we unmute Dr. Saurabh? Dr. Saurabh, am I audible now? So we'll move on to the next presenter. So we can get back to Dr. Saurabh later on.
Ma'am, am I audible?
Yes, you are. Please go on.
A very good afternoon to one and all present. I, Dr. Rahul Shah, is here to present my poster on the topic ligaments, a new dimension in the field of implant dentistry. To begin with, implantology has become an indispensable part of mainstream dentistry in the present era of dental practice. Albrechtsen et al. Later defined osseointegration as the direct contact between lining bone and implant at light microscopic level. This means that implants are functionally ankylosed to the bone without pedial support. Failure to occur because of any inflammation around them may cause severe bone loss, then do inflammation around the natural tooth with PDL. Therefore, implant with PDL has been thought of and developed, as PDL has been shown to possess immense regenerative capacity, restoring the strength of biomechanical tissue as well as restabilizing the innervation. A new approach to the replacement of tooth loss is introduced, that is tissue engineering of PDL. Cells are formed on the dental implant, then acting as a natural tooth. This new dimension in the field of implant dentistry is known as ligaplants. Now coming on to the interface of implant and PDL tissue, tissue-specified uniqueness was acquired after implantation, a new cementum-like layer typical for regeneration of PDL, orientation of cell and fiber across the non-mineralized peri-implant phase. PDL organization induced the cooperation of tissues surrounding the ligament site. Bone formation was induced around ligaplants, suggesting as osteogenic potential of new PDL. Now coming on to the preparation of ligaplant and how it is prepared. Temperature responses culture dishes are prepared and spread on the polystyrene culture dishes and then subjected to electron beam irradiation and rinsed with cold water. Human PDL cells are isolated from extracted tooth and placed into the culture dishes. Outdoor cells are cultured in humidified atmosphere of 5% carbon dioxide at 37 degrees Celsius for 48 hours. To harvest the cell sheet, human PDL cells are plated on temperature responsive cultural dishes and cultured at 37 degrees Celsius. The PDL cells are cultured in a bioreactor with titanium pin coated with hydroxyapatite. While preparing for ligaplant, certain precautions needs to be taken, like proper sterilization, proper culturing and cell growth, adequate duration of surface treatment. Properties of ligaplants: it acts as shock absorber, playing the role of peristome at the bone site, containing vital cells, provide proprioception. Advantages of ligaplant are firmly integrated without interlocking, alleviate problems such as gingival recession and bond defect, mimics insertion of natural tooth root in the alveolar process. Amount of bone loss in peri-implantitis is reduced. Concluding to that, ligaplant as tooth replacement seems to be the next advancement, as it is more likely to enhance the long-term stability with less inconvenience and discomfort to the patient. Further research on human with long-term follow-up could only validate the feasibility and success of ligaplants. There are certain disadvantages also factor affecting the host to accept the implant, or the growth of PDL in the socket is unpredictable. Cost of ligaplant is high due to limited facility. Culturing should be done with cautions. Studies in favor of ligaplants, Golpi et al. Say, according to application of ligaplant anchored implant, which have potential advantage over osseointegrated oral implants. Koi BH placed implant with culture analogous PDS cell in mandible of dogs, and histological revealed that after 3 months of healing, a layer of cementum-like tissue with inserting collagen fiber has been achieved on some implant surfaces. Thank you, sir.
Thank you, Dr. Rahul. Taken
Yes,
it
ma'am.
Rakesh, a question, please. Rakesh, sir, any questions?
Yeah, a good presentation and a new topic to discuss on. Rahul, will these ligaplants generate the same defense mechanism as our periodontal ligament in the oral cavity?
Yes, sir. As per studies, as ligaplant has the regenerative and reparative capacity around the tooth, it is maybe in future it is follow the mainstream to success rate of then osseointegrated implants.
Yeah, but then there is a difference if you have a fibrous tissue in between an implant and bone.
Yes, sir.
Won't that hamper the overall stress distribution of the implant? These might be some of the things which maybe with human trials and
Yes, sir. That's why some
right.
in vivo trials are
Right.
needed.
Yeah, right. Okay, fine. A good presentation, Rahul.
Thank you, sir.
Yeah, Rahul, it's a very good presentation. And you covered each and every corner of the ligaplant. So, what is the proliferation rate of the fibroblasts when they are incorporated onto the implant surface? In those studies, does they say anything about the survival and proliferation of fibroblasts?
Sir, after study says that after 3 months, they sees cementum, a layer, cementum like tissue like layer are found.
Cementum like tissue layer is formed.
And some studies are done on mice and canines.
Which model is more relevant when we do such studies for implant placement? Is it a canine model or a mice model or a rodent model?
Sir, canine model.
Model. More common is canine, more is primate. If due to ethical issues, canine model is more efficient.
Yes.
Right?
Yes, sir.
So what is the importance of temperature here when culturing? If the temperature alteration
Yes, sir.
is there,
Yes, sir.
does it affect?
Yes, sir. As cultural plates are temperature sensitive, we need a favorable environment. We need favorable environment for growth of tissue.
Oh, okay, very good.
Thank you, Rahul. We'll move to the next presenter.
Thank you.
Can we have the next present, please?
Hello, am I audible, ma'am?
Yes, Dr. Nikhil.
Yes. Shall I start, ma'am?
Yes, you have to keep your video on also, Dr. Nikhil.
Okay, ma'am.
Yes, please start.
Yeah. Yes, ma'am.
Yes, you can start.
Good afternoon, sir and ma'am. Today's my poster presentation topic is tissue adhesives in periodontics. So, what is tissue adhesive? Is a material that can bond tissues together when applied on their surface, and it prevents separation by transferring the applied loads from one tissue to the other. So, tissue adhesives are like single component which catalysts free adhesive capable of bonding at room temperature within the just few seconds, which is given by Cooper et al. In 1959. The tissue adhesives are divided into three categories, which acts like hemostats, glues, and sealants. Hemostats that can form the blood clot between the tissues, and the glues which reattach the lacerated or the traumatized tissues, and it acts as sealants which create a barrier to prevent the leakage of gases or the liquids. These tissue adhesives are divided into two components like natural and synthetic, which also called as natural bio-inspired and synthetic traditional. In natural, we use generally fibrin glue, gelatin, and albumin. In synthetic, we use cyanoacrylate, polyethylene glycol, and methacrylate anhydride. The natural ones have certain advantages and disadvantages. In advantages, they have like fast curing capability, good adhesion to the tissues, biocompatible and biodegradability, and it is having certain disadvantages like poor tissue adhesion. Relatively, it is expensive and having long preparation time to prepare. The synthetic ones having advantages like fast polymer adhesion, strong adhesion, ease of use, and relatively it is inexpensive. And it is having disadvantage like risk of swelling, possible allergic reactions, and relatively expensive. Certainly, in this presentation, we see fibrin glue, the mechanism of action of fibrin glue, in which the fibrin glue mimic the last stage of blood clotting. In this chart, we have given during the fibrinogen is converted into fibrin clot through a complex coagulation cascade. The fibrin glue typically consists of two major components, including the fibrinogen and the thrombin, in combination with the calcium chloride solution as the second component. Upon mixing these components, the fibrinogen is converted into fibrin monomer by thrombin, which consequently forms a polymer. In meantime, the thrombin activates the factor 13 and into the factor 13A, which stabilizes the network through the cross-linking of fibrin molecules by creating the amide bonds and forming an insoluble clot. In order to prevent this fibrinolysis, an anti-fibrinolytic agent is used in some formulations. And in this also, the certain properties are given about cyanoacrylate and fibrin glue. The fibrin glue properties having good hemostatic properties. It is having healing properties, and it acts as also sealants. The cyanoacrylate is also having high bonding strength, good wetting properties, and excellent adhesive properties. Apart from that, gelatin, the natural the natural tissue is having high bonding strength, lower cytotoxicity, and excellent biocompatibility. And polyethylene glycol having higher solubility, hygroscopic in nature, and excellent observing properties. According to the articles like Mohammada and Jenny have given that the natural tissue adhesives are more better than the synthetic tissue adhesives. So, thank you, sir.
Thank you, Dr. Nikhil. Chaitanya, sir, any questions?
Yeah, it's a good presentation, Mr. Nikhil.
Thank you, sir. Good afternoon, sir.
So you had told about the various tissue adhesives.
Yes, sir.
So what are the added advantage when compared to the suturing?
Sir, comparing, sir, between tissue adhesives and suturing, sir?
Suture, yeah.
Sir, the main advantage is like it is having, sir, antibacterial properties, sir, between tissue adhesives and like sutures. We are applying the tissue adhesives to the like to close the tissues. There is like no deposition of bacteria over there. But in case of sutures, there is should be the deposition of bacteria. This is the main property, sir, that antibacterial property.
These agent, how much amount of approximation we can expect? In suturing, we can expect a clear approximation.
Yes.
But with these fibrin glues or cyanoacrylates, can we expect that much amount of approximation of the tissues?
Yes, sir. It is. Yes, sir. Yes, sir.
Is there any literature supporting your statement, saying that these are better approximate the tissue?
No, sir. I have not seen that, sir. Literature, sir. Like, I didn't go through it, sir.
Yes, sir.
Yes, sir.
Rakesh, sir, any questions?
Yeah.
Yes, sir.
Good presentation overall.
Thank you.
Tissue adhesives, as you must be knowing,
Yes, sir.
have been in use for long.
Yes, sir.
Can you enumerate some of the reasons why they are not till date being clinically viable?
Sir, because sir, today's nowadays, sir, or previously, sir.
Nowadays, as in it has not been clinically viable. So why
Viable,
do you
yes.
feel that they are not being used at regular? They're not used regularly in clinics, right? So why do you
Yes, sir.
feel that? Why do you feel that they are not being used regularly?
Nowadays, sir, after doing the surgeries, sir, the patients are sir, not maintaining the proper oral hygiene and not listening to the
No. What I'm trying to ask you is, tissue adhesives are in the market since maybe now 10, 15 years, I guess.
Yes, sir.
And even in these 15 years, they have not been able to grab the clinics, doctors who are using them regularly in after their flap surgeries or maybe after that soft tissue
Yes, sir.
surgery. Why is that so?
Sir, it is costly, expensive than sutures, I think so.
So only
That's
the
why.
cost, you think, prevents a doctor from using some materials? Okay, you'll find it out when you start your own practice.
Yeah, sure, sir.
Yeah, thank you.
Thank you, sir. Thank you.
We have the poster 205 January, Dr. Saurabh.
Yes, ma'am, I'm here. Good afternoon, ma'am. Can you hear me?
Good afternoon.
Yes, perfect.
Video on also, Dr. Saurabh.
Good afternoon, sir. My name is Dr. Saurabh. The topic for today's poster presentation is herbs in periodontology. As we all know, the sole purpose of any branch of medicine is to strive to make human life happier and healthier with the available resources. Herbs are, kind of making a comeback into the so-called allopathic world. Herbal products symbolize safety when compared to synthetics, which are unsafe to humans and environment. Herbs have been used continuously for centuries to prevent and control disorders. Of late, the focus has been more on dental disorders. Herbal extracts are effective because they interact with specific chemical receptors in the body and cause a biochemical change in the body, thereby mimicking anti-inflammatory and properties. They minimize a lot of side effects which are associated with allopathic medicines. Herbal extracts have been used successfully since ages in dentistry as both tooth cleaning and antimicrobial agents. Now, how do these herbal extracts work? These basically work by the following mechanisms. They have an antimicrobial mechanism. Ma'am, my network is a little poor, so if I connect the video, the audio gets disconnected.
No problem, Dr. Saurabh.
I'm so sorry. So mechanism of action is antimicrobial. By inhibiting the microbial flora of the oral cavity, they kill they are bactericidal to the flora, thereby causing the reversal of gingivitis. They have anti-inflammatory action. They have a sedative action, and they have an anxiolytic action that by relieving the anxiety. Some commonly herbs that are used in dentistry are neem, turmeric, which has got anti-inflammatory properties, Centella asiatica, propolis, which is used in a mouthwash, garlic, aloe vera, ginger, and cloves. They work basically by having a lot of anti-carcinogenic, anti-inflammatory. Turmeric has got significant activity against the red complex bacteria. And Centella, if you see, it causes increase in collagen synthesis, thereby promoting healing. And ginger, as we all know, is a potent anti-inflammatory drugs. However, the research has been little less in herbs. Thereby, I can conclude by saying that many studies have shown the potency of herbal medicines as an alternative to conventional therapy. There still lies a void in research with respect to the clinical application. Future targeted trials in learning the mechanism of action through these herbs are warranted and thereby more commercially be available in the later stages. Thank you.
Thank you, Dr. Saurabh.
Thank you, ma'am.
Rajesh sir, step in the questions, please. Rajesh sir.
Yeah, good presentation.
Thank you, sir.
What do you feel would be a better way to, use these herbs, whether it is a topical or systemic?
So topical. So we've been doing studies using herbal mouthwashes. They haven't shown a significant improvement, but only the tag of it being herbal attracts the patients in practice.
There have been various studies which suggest the use of these herbs and proven to be very effective against varied number of bacteria
Correct.
which are
Correct.
present. Right.
Correct.
So,
Correct.
and one of the herb I feel that you have missed out is calendula, I guess.
Okay.
Yeah.
I have not mentioned that, sir. Yes.
You have not mentioned that because
I'm
many
not
of the studies, even calendula has been used, because
Yes.
it is used in faster healing.
Yes,
So
yes.
that is something that I feel that you must have added. Thank you.
I missed it. I'm sorry.
Thank you, sir.
Yeah, it's a good presentation.
Thank you, sir.
Very clear. Can you tell some commercially available products, paste or mouthwashes which are commercially
So Himalaya has got a mouthwash, sir, that we use as commercial.
available using herbal components?
Yeah, Himalaya has got a mouthwash.
Yeah.
And then
Yeah.
Propolis is inducted into a brand. I'm not very sure about the brand name of Propolis, which has been inducted. And neem is there as used in a lot of toothpaste. And then there's Miswak. And then there is Ramdev Baba's Patanjali products, which have a lot of herbal extracts and Ayurvedic extracts in it.
Colgate herbal toothpaste have you heard?
Colgate come up with something herbal, sir. But I don't know which component is there in that. So I'm not sure about that.
Yeah, and this curcumin, it is used, but there is recent studies involving the analogs of curcumin. Can you know any analogs of curcumin?
I'm unaware of that, sir. I'm unaware of that.
Oh, okay, it's okay. Good.
Hello.
Yes, sir.
Yeah, I have one last question.
Yes,
Do you know of any researchers in India who have worked on herbal medicine?
So Devanand Gupta, sir.
And who else?
So there is Patil SR.
Yeah.
And Devanand Gupta. I know of Devanand Gupta, sir. I've read a lot of his articles on herbal pressure.
Thank you. Thank you.
All right. Thank you so much, sir. Thank you, Sarika, ma'am. Thank you so much.
Thank you, Dr. Sarah.
Oh, bye. Bye.
Can we have a next presenter, please? Can we have a next presenter, please? I think the presenter has not connected. So we'll move on to the next poster. Dr. Aarti. Dr. Aarti, am I audible? It's poster 209. Dr. Aarti? Dr. Aarti, am I audible to you?
Hello,
Yes, doctor.
am I audible?
Yes, doctor. You have to put your video on also, please. Yes, you are audible.
Shall I start? Shall I start with the presentation?
Yes, please. Yes. But we can't see you. Can you put your video on, please?
Hello?
Yes, please. You can
Hello?
start.
Hello? Yeah.
Yes, Dr. Aarti, you're audible.
Yeah. I wish to start. A very good afternoon to all of you. Myself, Dr. Aarti, and I'm here to present my poster. My poster topic is a fibrin sealant in a periodontal surgery. Okay. Now coming to the introduction, the fibrin sealant, or it is also named as a fibrin glue, is a biological tissue adhesive which initiates the final stages of coagulation when a solution of the human fibrinogen is activated by the thrombin. So commercially, it is available in the two-component system. Also, it can be prepared autologously by the human blood centrifugation at the rate of 3000 RPM. The commercially available two-component system that it consists of two components. That first component includes the fibrinogen, then fibrinolactin, then factor 8. Addition to that, the plasminogen and traces of other plasma proteins. While the second component includes mainly the thrombin, the apritonin as a fibrinolytic agent, and calcium chloride. The both process right from conversion of the fibrinogen to the fibrin clot, which requires the presence of a thrombin, which converts the fibrinogen into the fibrin clot, and in the presence of factor 8, it further forms the cross-linked form of fibrin clot. Now coming to the properties of the fibrin sealant. Here mainly it consists of it shows the early hemostasis, and also it shows the tissue adhesiveness as compared to the suture technique. Then it shows the enhanced coagulation. Also it shows the reinforcement of the tissues better than the suture technique, and also it shows the tissue regenerative potential. Also it has the mechanical strength and stability, and shows the minimal inflammatory reactions. So now coming to the advantages and disadvantages of the fibrin sealant over the suturing. So the advantages of the fibrin sealant, it shows the simple, cost-effective, and easy to handle and safe technique, which makes the tissues adhere on its whole surface and reduces the total operating time. It is useful in inaccessible and aesthetically critical areas where sutures can show the more critical way. And the early hemostatic function is far better in a fibrin sealant. It decreases the formation of the hematoma. It is the least post-operative wound infection, and it shows it reduces the post-operative pain and discomfort. It saves the cost of preparation and sterilization and the storing of the instrument at the time of suture removal. While the disadvantages of suturing technique is it is already a technique sensitive, it requires time and patience, while it provides only the marginal fixation in the early stages. Then it takes time to control the bleeding, and meticulous suturing, it is difficult in inaccessible areas, and it requires time to achieve the hemostat. The hematoma might be found in the suturing technique, and suturing is prone for the post-operative wound infection. The post-operative discomfort and the cost is a cost-effective too, while suture removal shows the pain and discomfort. So now here we are going to discuss the three cases which I have selected. The case one.
Dr. Aarti, you've exceeded a time limit of 3 minutes of presentation.
So sorry, ma'am. Yes, so sorry.
So we'll give the opportunity for the judges to ask the questions.
Yeah,
kindly put
sure.
your video on, please.
Yeah.
Sir, questions, please.
Hello. Hello.
Yes, Dr. Aarti, you're audible.
Yeah, fine.
Chaitanya, sir.
Yeah. It's a good presentation, but you have tried to include so much of matter into the slide. But time management will be a little bit difficult if you include so many
Yes, I couldn't
points.
do this. I'm sorry.
It's okay. You tried your level best. So, what is the response of fibroblasts to this fibrin sealant? So when you apply the fibrin sealant, how the fibroblast will react?
In the fibroblast area. Sir, it
What?
helps in early hemostasis, as we discussed before. So fibroblast has a mainly important role in our early hemostasis. So that is the main advantage of fibrin sealant over the suturing.
One side you are telling it acts as a early hemostasis.
Yes, yes.
On the other side, the disadvantage is it takes time to control bleeding.
It takes time to control bleeding. No,
So early hemostasis means controlling bleeding, right?
yes, sir. Yes, sir. Yes, sir. No, it is a disadvantages of suturing. Yeah.
There are disadvantages of suturing, right? Okay.
It has, yes, sir. But it has a major limitation that it has a risk of transmitting diseases by the donor side. So
Yeah.
to overcome this, we need a vapor heating and the solvent detergent cleansing, which is actually cost effective. So that is a major drawback of a fibrin sealant, and it may cause definitely the allergic or anaphylactic reactions. So that is also a very major disadvantages over suturing. So conventionally suturing methods are definitely far useful than
So in this case report, which is beneficial for you?
Sorry,
You had
sir?
done cases, no? You had done the cases, no? Which method is beneficial? Fibrin sealant or suturing?
Not yet, sir. Frankly speaking, recently I also found such yes these articles recently. So I will look after those things. Yeah, definitely in my practice. Yeah. Thank you, sir.
Thank you, sir. Rakesh, sir, any questions?
Yeah. The cases that which you have shown, have you done those cases?
No, sir. No, sir. These are these are the cases from the article. Yeah. Yeah.
Okay, fine.
Thank you, sir.
Thank you.
Thank you, Dr. Aarti. We'll move on to our next presenter. Good afternoon, Dr. Deepali. Am I audible? Dr. Deepali? We can't hear you, Dr. Deepali. You need to unmute yourself. Am I audible, Dr. Deepali? Dr. Deepali, can you hear me? In the meantime, we can move to the next presenter so we can get her back later on. Can we have the next poster, please?
Hello, am I audible, ma'am?
Dr. Mayuri? Yes.
Yeah. Good afternoon, everyone. Today, I'm going to present a poster on a topic of comparative evaluation of the effectiveness of a demineralized freeze-dried bone allograft and other regenerative materials for the treatment of intrabony periodontal defects, systematic review, and the meta-analysis. Let's have a quick introduction. Periodontal regeneration has been shown to be effective in the treatment of various intrabony defects. Autogenous bone graft is considered as a gold standard, but it has a drawbacks like the second surgical site and donor side morbidity. So to overcome this, various allograft material has been introduced. Among them, the DFDB has shown to osteoconductive and the osteoinductive properties to a greater extent. Aims and objective: is to evaluate and compare the effectiveness of a DEF-DBA and other regenerative materials in the treatment of the various intra-bony defects. Moving to the material and methods, this article is first registered in the Prospero and it is designed according to the PRISMA guideline 2009 and included both RCT and the non-RCT studies. And search strategies included are the PubMed, Cochrane, Google Scholar from 1st January 1989 to 31st March 2020. 1,130 articles we got after the removal of duplicates, from which 1,105 excluded after the title search. So 25 full text articles were assessed and total number of 14 sites were included in the systematic review, from which the meta-analysis was done in 10 studies. So risk of bias were calculated for RCT and the non-RCT, and Robbins 1, a tool is used for non-RCT, and Cochrane risk of bias tool used for the RCT. Moving towards the result and the discussion, this systematic review for RCT and non-RCT study reveals that the clinical effectiveness of a DFDBA bone graft than compared to the other regenerative material in the treatment of intrabony periodontal defect. According to the meta-analysis outcome, DFDBA shows the better results in terms of gingival recession, pocket depth reduction, and the radiographic percentage and the radiographic bone fill compared to other regenerative materials. Moving towards the conclusion, within the limitation of the present systematic review and the meta-analysis, the use of DFDBA shows the better results in terms of gingival recession, pocket depth reduction, linear radiographic bone fill, and the percentage of bone fill when compared to the other regenerative material in the treatment of intrabony periodontal defect, except the clinical attachment gain. Thank you, sir.
Rakesh, sir, any questions?
A good compilation, doctor.
Yes, sir. Thanks, sir.
Yeah. But the in these meta-analysis that we have carried out, whether the newer regenerative materials were being considered?
Yeah, sir. All other meta-analysis, I did this meta-analysis from 1989 to till 31st March 2020. All the RCT study and the non-RCT studies were included, and only sir RCT studies were used for the meta-analysis. For the non-RCT study, it is not possible to do the meta-analysis as there is only one study available at a 6-month interval with a standard deviation. So forest plot for these studies are not possible. So only 10 articles were included in the meta-analysis where the systematic review is done for both all the 14 articles. All other material which are all the studies, randomized control trial and non-randomized control trial were included in this study, sir.
Oh.
Thank you, sir.
Dr. Mayuri?
Yes, sir.
I'm sorry. Am I audible?
Yes, sir. You are audible.
I'm sorry. Actually, it was a good try to compile all the systematic review and meta-analysis in a single poster at a period of 3 minutes. You have done really very well to manage the time also. So can you tell what is the first difference between a systematic review and a meta-analysis?
Systematic review is a review in which the secondary data is collected and the statistical analysis of that data is used. And the meta-analysis is the analysis of the all the systematically arranged data. And in the meta-analysis, we go for the forest plot and the funnel plot. The funnel plot is used for bias, whereas the forest plot, all the data is collected in a one plot. And
So
it is analyzed. It's so all these.
Okay, it's okay. What property of DFDBA had made it more good clinical outcomes when compared to other regenerative materials?
Sir, according to this review, I have found that the gingival recession, pocket depth reduction, and the percentage of bone fill mainly, sir. Radiographic, linear radiographic percentage of bone fill.
Yeah.
Actually,
so in
sir,
DFDBA, which component had helped to gain that clinical achievement?
Sir, from the systematic review, we cannot say the exact component, sir.
So normally, in your view, what does DFDBA contains?
So demineralized freeze-dried bone allograft.
So what does demineralization releases? from the bone?
Yes, sir.
What does it releases when you demineralize a bone?
Sir, osteoblastic properties, it increases.
Any proteins it will release? Have you heard about bone morphogenic proteins?
The bone morphogenic protein, which causes the new bone formation and the vascularization and ability to stimulate the cell attachment
TFDBA
and cell
has
migration.
more. Yeah. So does
Yeah, it
every
continues.
intrabony defect classification, every intrabony defect class will heal more with TFDBA or any
Yes.
specific defect?
Yes, so that's what within the limitation of this review, it included all the bone defects, like all the RCSTs has a various defects, like 3-wall, 1-wall, 2-wall, and the combination.
Okay.
So that is the limitation, sir, that it should be in a specific only 3-wall defect. But the what are the articles published are including all, sir. So with the
Okay.
3-wall defects, more good regeneration properties shown. Sir.
Oh,
Thank you, sir.
okay.
Thank you, Dr. Mayuri. We'll move on to the next presenter.
Am I audible, ma'am? Hello, ma'am.
Yeah, you are audible.
Shall I start, sir?
Yes, ma'am. Yes, doctor, you can start.
Good afternoon, everyone. For today's poster presentation competition, I'll be presenting a systematic review and meta-analysis on comparative evaluation of effectiveness of papilla preservation flap with regenerative material and papilla preservation flap alone for the treatment of intrabony periodontal defects. As we all know, papilla preservation flap is a gold standard technique for the treatment of intrabony periodontal defects. But along with the papilla preservation flap, various biomaterials can also be used for the treatment of intrabony periodontal defects like autogenous bone graft, MDOGA, and DFDBA, FDBA. In the field of evidence-based dentistry, systematic reviews and meta-analysis plays an important role as they can search and assess best available evidences, and meta-analysis reinforces and strengthens the evidences gathered by systematic review. So this systematic review and meta-analysis mainly focuses on RCTs carried out between papilla preservation flap with regenerative material and papilla preservation flap alone for the treatment of intrabony periodontal defects. As there was a scarcity in literature regarding this topic, with the aim to evaluate and compare the effectiveness of papilla preservation flap, this study was planned. The current systematic review was registered in Prospero and the protocol was prepared according to the PRISMA guidelines. 3 databases have been assessed and those are PubMed, Cochrane, and Google Scholar up to 30th April 2020. And outcomes assessed were clinical attachment level gain, pocket probing depth reduction, gingival recession increase, and intrabony defect depth reduction. Only RCTs were included. These are the search strategies for PubMed and Cochrane. So the PRISMA flow diagram for the current systematic review included first records were searched through databases and total 1764 articles were analyzed, then out of which 22 were from PubMed, 42 were from Cochrane, and 1700 from Google Scholar. After the duplicates removal, 1685 articles were there. Then all the articles were screened and after abstract reading, 1673 articles were excluded and total 12 articles were eligible for full text reading, out of which 6 articles were plus meta-analysis.
Dr. Yugandhara, you're not audible.
Sorry for the interruption, ma'am. For gingival, increase in gingival recession, meta-analysis was not possible for 2 years. Only 1 year meta-analysis was done, and results were non-conclusive. And for IBD reduction, also it favors the experimental group. As a discussion in the systematic review and meta-analysis, it was observed that results of experimental groups were better than control groups at a consecutive follow-up periods for all the 4 outcomes. And this systematic review and meta-analysis shows the moderate strength of evidence and supports the findings of systematic review by Nibali et al. Done in 2020. But the results of this systematic review and meta-analysis are more confirmatory because of strict and specific inclusion criteria. Within the limitations of this systematic review and meta-analysis, I would like to conclude that papilla preservation flap with regenerative material is more effective than papilla preservation flap alone for the treatment of intrabony periodontal defects. Thank you. Hello.
It's not really audible. Rakesh sir, any questions? Chaitanya sir?
Thank you.
Yeah, it was a good presentation.
Thank you, sir.
So can you tell which type of papilla preservation, either it is a simplified or a modified, which one has a more benefit in the systematic review? Have they classified any type of technique?
Sir, in this systematic review, I have not compared all the types of papilla preservation flap. I have compared treatment with papilla preservation flap and with regenerative material and without regenerative material. So there was no comparison between the flaps. But as entire papilla preservation flap is yes, sir.
Technique is not compared here. Only the without material and with material.
No, sir, I have not compared incision technique. Yes, sir, with material and without material. But I have included all articles with all the type of papilla preservation flap.
Okay.
Because there was no sufficient data. If I have to compare the incision techniques, then there was not sufficient data to conduct a systematic review.
Rakesh sir, any questions?
No, thank you.
Thank you, sir. We'll move on to our next presenter. Can we have the poster 208, Dr. Deepali?
Hello, ma'am. Ma'am, 20.
Dr. Deepali, we can. I think we lost Dr. Deepali again. So, Dr. Chambivi?
Yes, ma'am. Good morning, ma'am.
A very good afternoon. Please keep your video on and you can go into the presentation.
Ma'am, it's saying host has stopped the video.
Just one second. I can get back to you. Please make sure that you're in the good range because I think your net is unstable. Dr. Shambhavi, can you see your poster?
No, ma'am. Yes, ma'am. Now I can see my poster. Ma'am, due to some technical issue, I'm not able to the video.
Your video is off, Dr. Shambhavi. Yes, it's on now, but we can't see you.
Shall I continue?
Yes.
Very good afternoon to one and all present here. The topic of my poster is periodontal microsurgery, magnifying periodontium for surgical precision. So microsurgery refers to surgical procedure performed under magnification. History of magnification dates back to 1694 when Anton van Leeuwenhoek constructed the first compound lens microscope. Apotheker and Jacob first introduced commercial operating microscope in dentistry in the year of 1981. Microsurgery was introduced in the field of periodontics in the year of 1992. So coming to the microsurgical triad, so microsurgical triad comprises of illumination, magnification, and increased precision in the delivery of the surgical skills. Illumination is achieved through the fiber optic technology, which has improved the methods of focusing light on specific areas and is a standard feature of surgical operating microscope. Magnification can be achieved through the use of loops and microscope. So loops can be simple, compound, or prism in design. They're available in different designs, such as TTL, that is through the lens, and flip-up loops. Prism loops are the most optically advanced type of loop magnification and is commonly used in dentistry, offering improved ergonomics, posture, as well as significant advancement in the optical performance. So surgical microscope is a complicated system of lens that allows magnification of approximately 4 to 40x. An operating microscope consists of eyepieces, binocular tubes, magnification changer, objective lens, and lighting unit. So magnification recommended for surgical intervention ranges from 2.5x to 20x. So in periodontal microsurgery, magnification of 4x to 5x is used for loop spectacles and 10x to 20x for microscope. As the magnification increases, the depth of field decreases. Magnification of 6 to 8x is recommended for surgical intervention of entire quadrant. A basic set of microsurgical instrument consists of microscalpel holder, micro scissors, micro forceps, and elevators. Ophthalmic blades can also be used, and sutures used in microsurgery ranges from 6 to 90. The clinical applications of microsurgery are the root surface debridement, papillary reconstruction, gingival recession coverage, treatment of isolated intrabony defects, implant placement, crown lengthening, etc. So there are several advantages of the periodontal microsurgery over the conventional periodontal surgeries. Basically, the periodontal microsurgery provides improved illumination and magnification of the surgical field that permits proper access with increased accuracy and minimal tissue trauma. A primary wound closure minimizes bacterial contamination, hence providing favorable condition for periodontal regeneration. So minimal marginal tissue recession and thus improved aesthetics and a very limited intra and post-operative morbidity and thereby high patient acceptance and satisfaction. So overall, microsurgery provides advantages of reduced surgical chair time, increased wound stability, better aesthetics. Thank you.
Yeah, it was a nice presentation. So this microsurgical triad is present now.
Yes, sir.
Who had done this microsurgical triad?
Sir, I'll have to find out. Sorry, sir.
So this magnification lenses are there.
Yes, sir.
So which type of magnification lens will be more useful when we use?
Sir, in pedontal microsurgery, sir.
Periodontic. Yeah.
So generally, we use the compounded prism designs with the magnification of 2.5 to 4x, sir.
2.5 to 4x.
Yes, sir.
So what are the disadvantages with this microsurgical procedure?
So the disadvantages of microsurgery can be, sir, basically, sir, it's not that cost effective, and so with the use of loops, there are eye fatigue, because we have to have a proper eye and hand coordination. So it might result in eye. Initially, we can have eye fatigue and more. So loss
More
of
practice to be required.
Sir?
More practice to be required when we perform under a microscope or by using these loops, right? Precision should be present while handling the instrument.
Yes.
Sutures, as the area of the working field will be very less.
Yes, sir.
Yeah.
Thank you, sir. Rakesh, sir, any questions?
Now, I had the same question about the disadvantages of the surgery. And as Dr. Chaitanya rightly called out, there is a steep learning curve.
Yes, yes, the steep learning curve.
Yeah, it's a steep learning curve from conventional to a microsurgery, a surgical approach.
Yes.
Nice presentation. Thank you, Doc.
Thank you. Thank you.
Thank you, sir. Thank you, Dr. Chambali. Moving on to our next presenter. When we have the poster 208. Poster 208, please. Dr. Tavleen?
Yes, ma'am. Am I audible?
It's very faint. Your voice is very faint, doctor.
Ma'am, is it better now?
Yes, better. And you need to keep your video on also, please.
Ma'am, actually, I'm switching it on, but the host is not letting me in. Just stopped it.
No, you are in the meeting. We can see you.
Okay. Good afternoon, ma'am. Good afternoon, everyone. Ma'am, I may start?
Yes, please.
Good afternoon, everyone. Today, the topic of my presentation is e-cigarettes to replace e-cigarettes in a new era. So what is basically a cigarette? A cigarette is some tobacco leaves rolled up in a thin paper that are used for smoking, whereas e-cigarettes, cigarettes are the traditional cigarettes that we have been using since many eras. But e-cigarettes are the electronic cigarettes. These are new devices, also known as vapes. It has been very much into use nowadays. It has many parts. It has parts like a vapor where we can smoke, a cartridge where we can put the glycerine, the vegetable glycerine, or propylene glycol, and a nicotine cartridge, and the lithium batteries. Then coming on to the compositions, the composition of cigarette and compared to the e-cigarette, the e-cigarette has less harmful components as compared to t-cigarettes, cause the amount of charcoal, the amount of tar that is produced due to the carbon monoxide is much more as compared to e-cigarettes in normal traditional cigarettes. Also, the benefit of choice that we get in the e-cigarette is that we can control the nicotine amount in the e-cigarettes. The cartridge has 2 to 3 milligram of nicotine amount, whereas in the traditional cigarettes we weren't able to control them. It was estimated that 14 to 21 milligram of nicotine is there in the normal traditional cigarette. Plus the new era, according to plus the new among the youngsters, according to the National Tobacco Youth Organization, it has been seen that the system of smoking hookahs and taking cigarettes is now the trend is changing, and more students are opting for e-cigarettes. In my personal opinion, it is very important for the youth to make them understand about the nicotine replacement therapies. E-cigarettes are one of the better choices. I don't say that it eliminates periodontitis or it seizes it, but yes, for the replacement therapy it is one of the good choice. So as to we should motivate the patient in our clinic so as to eliminate the use of nicotine in their day-to-day life. Also, there are many harmful components that I would like to tell you in the traditional cigarettes that are carbon monoxide that produces too much tar. Then there are some components like formaldehyde that are used in the crackers and in some fertilizers. They have also been used in some nail paints. So as you can see, such harmful products are going inside your body. So it's better if we start to replace the normal traditional cigarettes to the new replacement therapies. Ma'am, do I have more time?
Thank you, Dr. Tavleen. No, you have extended your time limit. Dr. Chaitanya, sir, any questions?
Yeah. So since how long do you know about this e-cigarette, doctor?
So actually, so I have some of my friends in Canada, and they are smoking this e-cigarette. And I've asked them personally after taking this poster into consideration. I've asked them personally, and they were also telling that you can also regulate the puffs. The amount of smoke that is you are inhaling. There are many cigarettes that tell how much puff you take per day.
Yeah, I'm asking you.
Yes, sir.
And how many years back does these e-cigarettes have been introduced into the market?
So into the market, sir, in 2000 and so 2014, it was the first e-cigarette that was introduced. I am sorry, I cannot recall the author.
Yeah, around 8 to 10 years back, they have been introduced.
Yes,
But
sir.
do you know, in the recent times, in USA, these e-cigarettes have been banned. Can you tell
Yes, sir.
what is the reason?
Yes, sir. So obviously they are also not very much helpful, because patients tend to smoke more. There have been many studies by Fung ex al, a Chinese author, in 2020. So he has been studying the three categories, and he has also been telling that many people are smoking. They tend to smoke more, so equivalent amount, approximately equivalent amount. And so plus it has been banned because the amount of nicotine that a person is smoking, they reload it again and again. So obviously it has a benefit of choice.
Actually, they are banned due to the explosion of these e-cigarettes in the mouth of the patient. So there
Yes,
are
sir.
few case reports where there are explosion of these e-cigarettes.
Yes,
So
sir.
that
Yes,
is the
sir.
prime reason for
Yes,
banning
sir.
the e-cigarettes in
Yes,
United
sir.
States of America.
Yes, sir.
Okay.
Yes. Yes,
So
sir.
do you prefer this e-cigarette for your patient in future?
Sir, in person, I would recommend a patient to ideally to cease any tobacco component. So obviously, I would recommend other replacement therapies like Nicotex chewing gums, and so I would go for if the patient is not willing, then I can go for the replacement drugs that are bupropion and varicocin.
Okay, okay. It's okay.
Yes, sir.
Good.
Thank you.
Practice for any questions?
Yeah. Have you heard of the term vaping?
So yes, vaping is same as that is done with the e-cigarette. So it's just the aerosol that is produced, and so the vegetable oil is the vegetable glycerin is put in the e-cigarette cartridges.
What are the disadvantages, or what are the effects of that?
So effects are approximately same. So as compared to T-cigarette, if we say, so the aerosol production, so it gives, so it impacts on the lungs. Uh, so what I feel is that nicotine is a component, is one component that mimics acetylcholine, and which is also very much harmful for the periodontal health.
These e-cigarettes have been shown to increase the heart rate as well. They
Yes,
have
sir.
been shown to cause DNA damages. They have been shown to cause mutagenesis in the cells.
Yes, sir.
I would highly, recommend you and your friends whom you have talked
Yes, sir.
to stop these e-cigarettes as well,
Yes,
because
sir.
they are as harmful as your conventional cigarettes.
Yes, sir.
Thank you.
Yes, sir. Thank you.
Thank you, sir. Thank you, Dr. Taveen. We'll move on to our next presenter. Can we have the next poster, please? Dr. Deepali?
Yes. Am I audible?
Dr. Deepali, I think your network is not stable. Kindly check with your net connection.
audible?
Dr. Deepali, make sure that you are in a good network area because your voice is breaking in. There's interruption.
Ma'am, my video is there or not?
No,
is it okay now?
Yes, you're audible, but your video is off. Yes.
Okay, ma'am. So shall I present with the of ma'am, can I present now?
Dr. Deepali, there's a lot of interruption. We cannot hear you clearly. You're not clear. Dr. Deepali?
Ma'am, can I start now?
Yes, please.
Okay, ma'am. Ma'am, am I audible now?
Yes, you are audible.
Yes, ma'am. Hello. Am I audible now?
Yes, doctor, you are audible. Please go on.
Yes, ma'am. Good afternoon. Good afternoon, everyone. Today, I'll be presenting my poster on consent as an overlooked aspect of research. As you can see, out of the pillars of bioethics, informed consent forms the most strongest pillar of bioethics. Now, what is a consent? A informed consent is a voluntary written consent which should be obtained in an informed consent document from each participant to protect each individual's freedom of choice. What are the contents of consent? The content of consent consists of the discussion about the benefit and the risk associated with the participation, as well as followed by the procedure of the data collection, the main purpose of the study, voluntary participation and the withdrawal at any time, and signature of both participant and researcher. Now, why it is needed? It is needed to protect the individual freedom of choice and respect the we as healthcare providers are universally governed by the code of ethics. It is a basic principle of patient's autonomy and respect. Unfortunately, in today's busy times, this has become a stepchild of healthcare and research, where on one hand, we boast to distinguish achievements, on the other hand, forget the basic treatment. That is to respect and take consent before carrying out even the minutest of the procedure on the patient. Since informed consent form one of the most solid foundation of research methodology, it's time we step back and shed light on the often overlooked and neglected aspect of healthcare and research. A consent is not assumed, coerced, implied, or convinced. Overlooking this step has its legal implications. Hence, it is always better to be safe than sorry. So I would like to conclude by saying, let's be empathetic to the patient's plight, lead them from darkness to light, empower them with informed consent as their basic right. A ballot is stronger than any bullet. It's okay if patient refuse after all. It's right to choose. It's okay if the patient refuse. After all, it's their right to choose. Thank you.
Thank you, Dr. Deepali. Is there any questions?
Yeah, it's a good presentation. So
Thank you, sir.
what are the four components of informed consent?
The component of informed consent are, sir, the benefit and the risk involved in the procedure. We explain the concerns of the patient about the treatment or the research we are going to do. The signature are very important, and also the purpose why we are doing any research or why we are doing any procedure on the patient.
What do you mean by implied consent?
And also the confidentiality.
What do you
So
mean by
implied consent is yes, sir. Implied consent means the patient passively cooperate in a process without discussion or formal consent. The principle of good communication applies in these circumstances.
Okay.
So it is given in a review article by Hina Kakkad in 2014.
Okay. Okay.
Yes.
Any question? Rakesh, sir?
So any other question?
No, thank you.
Thank you, Dr. Rakesh. Thank you, Dr. Dipali. We'll move on to our next presenter.
Thank you, ma'am.
I think we have concluded with all the presentations. Janvi, please just check if we've missed on anybody.
Am I audible, ma'am?
Yes, Dr. Shilpi.
Good afternoon to all. Today I'm going to present my poster on the topic stem cells in periodontal regeneration and overview. Stem cells are undifferentiated cell capable of self-renewal and multi-lineages differentiation. There are two types of stem cells on the basis of origin, embryonic and adult stem cells. Embryonic stem cells are pluripotent stem cells derived from undifferentiated inner cell mass of blastocysts and can differentiate into almost all cell lineages including ectoderm, mesoderm and endoderm. Adult stem cells, these stem cells come from developed organs and tissue in the body. They are used by the body to repair and replace damaged tissue in the same area in which they are found. Adult stem cells are of many types according to their source: hematopoietic stem cells, epithelial stem cells, neuronal stem cells, mesenchymal stem cells. We can divide mesenchymal stem cells into dental and non-dental origin. Now, the dental origin: stem cells from human exfoliated deciduous teeth isolated from the pulp of human deciduous teeth has higher proliferation rate. They induce bone formation, regenerate dentine, but they are unable to regenerate a complete dentine pulp complex in vivo. Dental pulp stem cells isolated from the pulp of healthy adult tooth. Dental pulp stem cells generate a dentine pulp-like complex that is composed of mineralized matrix with tubules lined with odontoblasts. Next, stem cells from apical papilla induce isolated from tooth root apex induce root formation. They have capacity to regenerate dentine than dental pulp stem cells because the dental papilla contains higher number of adult stem cells compared to the mature pulp. Dental follicle stem cells isolate from dental follicle of human third molar, able to generate cementum bone periodontal ligament. Next, periodontal ligament stem cells obtained from the root of extracted teeth. These cells are present in the perivascular niches of periodontal ligament. Now, according to their potency, there are 5 types. Totipotent cells, ability to differentiate into all types, can form any cells of the embryo as well as placenta, for example, fertilized egg or zygote. Pluripotent cells, ability to differentiate into almost all types except placental tissue, example, cells from the inner cell mass of the blastocysts. Multipotent, which only generate specific lineages of cells, example, hematopoietic and mesenchymal stem cells. Oligopotent, ability to differentiate into a few cell types, example, lymphoid and myeloid stem cells. Unipotent stem cells, one stem cell has the capacity to differentiate into only one cell type, example, muscle stem cells and cardiac stem cells. Now, non-dental stem cells used for tooth and periodontal regeneration are primarily bone marrow mesenchymal stem cells and adipose-derived stem cells. Now, coming on to the tissue engineering triad, it comprised of cells, scaffolds, and signaling molecules. Cells, mesenchymal dental stem cells are the major cell source, multipotent, that proliferate extensively, can be safely cryopreserved, possess immunosuppressive properties, and express mesenchymal markers. Signaling molecules, growth factors and signaling molecules have the ability to stimulate cellular proliferation and cellular differentiation. Important families of growth factors that play a vital role are transforming growth factor, beta, and bone morphogenic protein. Scaffolds should be biocompatible, non-toxic, and have optimal physical and mechanical properties, should be highly porous to facilitate cell seeding and diffusion of nutrients. It provides structural integrity. Material used for scaffolds include both synthetic and natural. Clinical applications are periodontal regeneration, implant site preparation, 3-wall bony defect, biroot formation, and bioengineered tooth regeneration. Now, the conclusion, mesenchymal dental stem cells derived from teeth are accessible multipotent cells with the capacity to differentiate into distinct cell types. This new source of stem cells could be of benefits in cellular therapy and the eventual development of techniques for use in regenerative and degenerative disease. Thank you.
Chaitanya sir, any questions?
No.
Thank you, sir. Rakesh sir?
Yes, a very nice presentation. Can you tell me one major limitation of using these stem cells in our clinical practice?
Sir, ethical and legal concern, because a few stem cells.
No. Once you start using it regularly, I don't think so. There will be any ethical concerns.
A few stem cells isolated from the healthy tooth.
But you'll be using third molars, which are extracted.
Yes, sir.
Fine. Thank you.
Thank you, sir.
This was the last poster presentation for this session. Is there anybody we've missed out on? Yes, we have concluded the session. We have finished all the presentations in the session. I will take this opportunity to thank Dr. Chaitanya sir and Dr. Rakesh both for gracing us with their presence and sharing the session from on behalf of the organizing and the scientific committee of 45th ISP National Conference, Pune. The heartfelt gratitude and thanks to both of you all. And I thank all the participants for their seamless presentation and my hall coordinators also. Thank you, sir. It's just a request to both of you all to fill in the evaluation sheets and to mail it on the given email ID so we could just tally up the scores.
Yeah, I would also thank the organizing committee for the organization. It's a very planned and a very organized organization. And we'll send the evaluation sheet in a period of time. Okay.
Yes,
Thank you.
you.